हो गया ना?
शिरीष,
हाँ हो गया ना?
हाँ मैंने चैट बॉक्स में लिंक डाला हुआ है।
ओके, थैंक यू अमित भाई, थैंक यू
हाँ
सो मच।
मैं होस्ट बना रहा हूँ आपको, मैं लीव कर रहा हूँ मीटिंग।
डन डन डन, ठीक है, आप लिख करो।
क्योंकि क्या मैं नेटवर्क में नहीं हूँ, मैं ट्रेन में हूँ।
हाँ, नो प्रॉब्लम, नो प्रॉब्लम, नो प्रॉब्लम।
Hello, ma'am. Good afternoon, ma'am.
Good afternoon. Can you hear me?
Yes, ma'am, I can hear you.
Wonderful.
Yeah.
So just one very quick question. When we do actually log in for the webinar at, well, in half an hour, do we use the same link to come in?
Same link, ma'am. Ma'am, you have to just rename yourself since the name is going pandemic. So once you
Okay.
relog in, you just rename yourself.
Okay. And how do I rename myself? Ah, there we go.
Just,
Yes,
you just
found
click
it.
on that. Done.
Perfect. Is there anything else? I tried to share and I could see my
You
slides.
can.
That
I
should work.
already started the hosting, right, ma'am? You can now share. Done, ma'am. Perfect.
That would work, isn't it? Yeah.
Yes, ma'am. It's visible.
Brilliant. Okay. Is there anything else I
Okay.
need to do, or I can go and
No,
come
ma'am.
back?
No, ma'am. You're gonna come back once again.
Wonderful. Thank you.
Thank you so much, ma'am. Good afternoon, Rita, ma'am.
Shirish, can you hear?
Hi, good afternoon, ma'am. Yeah, I can hear you now.
Already?
Yes, ma'am, everything is ready.
We are going live at 5 o'clock.
Yeah,
Are
ma'am.
we live?
Yeah, ma'am, we are already live on YouTube, but webinar I haven't started yet.
Will we be skipping that part? They'll be cutting it off later
Yes,
on?
yes, ma'am, yes. Dr. Arjuna Dixit has already checked the screen. She will be joining back.
They have tried their PPT and everything now?
Yes, Dr. Arjuna ma'am has already checked.
Okay. I don't have PPT.
Yeah, no.
Okay, I've sent the message to the group. Hello, Vartika ma'am.
Hello, is it Manisha?
Yep.
Oh, great. Rename yourself, no?
Oh, huh.
So all set?
Hoping, ma'am. Ma'am, I could not contact with this Dr. Arun sir.
Okay, but Dr. Arun sir had message, in the end that
We
regarding
saw the
that link.
message. Yeah.
Yeah, and
I
then
believe ma'am also saw, though she didn't pick up the call, ma'am. So I hope they have seen.
yeah. So I got message. Dr. Asha Rao Mam has texted, no, that she'll be a little late. She's got stuck up somewhere.
I have no
So
idea. Okay.
it's already.
Ma'am.
ठीक है.
हो जाएगा
हाँ. कोई नहीं. सब हो जाना.
Yes, ma'am.
ठीक है.
बाप रे.
लगी नहीं रहा नाइट ड्यूटी की हुई है. हाँ.
माँ बहुत कॉफी पी रखी है आई एम प्रीटी श्योर बाय द टाइम पता है क्विज वाला पार्ट आएगा आई विल बी स्नोरिंग ओके
You have, see, Monisha, you are taking the end thing, right?
हाँ.
So I'll be introducing shuru mein when these people would be introducing me and you, and then I would be introducing Dr. Asha Mam according to that flow, right?
हाँ, so you will be doing the everything, ma'am, up till that chairperson wala thing, है ना?
No, I'll be doing everything till your panel discussion.
हाँ.
ठीक है, जब वो डॉक्टर नीना का खत्म हो जाएगा ना,
हाँ.
then I will be calling upon you. जब when I'll request Dr. Fessy Lewis sir to give his comments.
हाँ.
Then after that, then I'll call you.
ठीक है, ma'am.
To call Asha Mam.
Asha Ma'am and Ritu Ma'am. हाँ. ठीक है.
ठीक है ना, so you will be introducing Ritu Ma'am and Asha Ma'am, and then you will be.
आशा मैम को तो अभी हम लोग इंट्रोड्यूस करेंगे ना? नहीं, स्टार्टिंग में तो कर देंगे एज अ मॉडरेटर. नहीं करेंगे? है नहीं है, हम मुझे पता नहीं, मैंने फ्लो नहीं देखा. एक सेकंड.
Yeah, very good evening, ma'am.
Good evening.
Hello, you have to rename yourself.
Yeah, ma'am, I'm Pankaj Sahu, Zonal Manager,
Yes.
Alembic.
Yes.
How are you, ma'am?
We're doing perfect. Acha, keep our intro very short and sweet, okay? Can you
Yeah,
just
yes, ma'am.
this is that CV wala slide, right? This slide, this current.
Yes, ma'am. Yeah, this is the same.
Can we go ahead and can we see
Yeah,
which is in sequence wise?
Yeah,
मैम
ma'am.
आप अपना बता दो, आप मतलब आपका तो खैर पूरा ही सुना मेरा मैम
कोई शौक नहीं है पूरा सुनने का।
नहीं पूरा मतलब वो तो नहीं मेरा
Short
मेरा
and
बहुत कूड़ा कचड़े की तरह रखा हुआ है इसलिए मैं
नहीं, it's okay.
उनको बस बता
Please, Mr. Sahu, ask everyone to rename themselves, or you rename ma'am and everyone, no?
Yeah, ma'am. I also from my end will rename.
सर जस्ट मेरा ना बस स्टार्टिंग का फर्स्ट थर्ड पॉइंट बस फर्स्ट और थर्ड पॉइंट बस आगे कुछ नहीं, ठीक है? दैट्स ऑल यू हैव टू टेल. आप आगे बढ़ जाओ. You are introducing us, right?
Yes, Pankaj sir will be introducing.
हाँ.
Yes, ma'am. Monisha, ma'am, I'm Pankaj. I will introduce you, ma'am.
So Pankaj sir, just introduce the first and third line. That's all. मेरे में.
That's all, ma'am. Need not to go in deep.
No, भैया कुछ नहीं, ठीक है?
Fine,
Hi,
ma'am. Fine.
Manisha.
Hi, ma'am.
Good evening.
Hi. Good evening. I cannot see. Oh, this is how
आगे करना पंकज.
we do not see the other audience like a list, is it? Like you see in the regular Zoom?
No, ma'am. This is a webinar setup, so we won't be. We can just see the participants who are coming. So here we'll be seeing the panelists who are there for the meeting.
So can I? Who are the panelists who joined already?
Good evening, ma'am.
Hi, Chitra. Looking very smart. Hi.
Good evening, ma'am.
Good evening. How are you? I just want to check my slides. How do I do that?
Yeah, just a second, ma'am. I just stop sharing.
Hello, ma'am.
Yeah, ma'am. You can now just share your screen.
Yeah, 1 second.
Hello, Chitra Didi. Hello.
Yeah, Monisha, ma'am.
Yeah.
I need to just to share your degree, ma'am, as well as you are in a senior resident doctor.
Yes, the first and
That's
third.
all,
Yes,
no?
that's all. That's
Fine,
all.
ma'am. Fine, ma'am.
Dr. Asha Ma'am.
Hi, Pragati. How are you?
Fine.
Just trying to share my screen. Share screen. Yeah, I think I'm sure the slides are moving.
Yes,
fine.
yes, perfect.
Yep. Have Dr. Arjuna Dixit,
Yes, ma'am. They have checked. She has checked, ma'am.
She has
Just
checked
walked
the
out
slides.
right now. Yeah.
Dr. Ritu Khanna is here. Hi, Ritu. Dr. Nina is yet to join, right? Nina Malhotra.
Yes.
Hi, Ritu.
Hello, good evening, ma'am.
Good evening. How are you?
Hi, fine, madam.
Good evening, ma'am.
Hi.
Hi, Chitra.
Hi, ma'am.
Hi, Manisha.
Hello, ma'am.
Ritu and me both are in blue.
Yeah. Yeah. Everybody eagerly waiting for the session.
So I think Ramani is not able to join. You can come after. You can come exactly at 5.
I think we have another 15 minutes.
Yeah. Good. Once I log in, I'm happy. That's it.
Yeah, it's checked.
But there's a fear of perpetually being late.
Yeah,
For
definitely.
some reason.
Yeah, very good evening, Asha, ma'am.
Good evening.
Ma'am,
Hi,
this
hi.
is Pankaj Sahu. I just had a word on telephonically to you, ma'am.
Oh, yes. Yeah.
I hope you are doing well, ma'am.
Yeah, all of us are doing well. How are you?
Yeah, we are quite fine, ma'am. Thanks a lot, ma'am. So, ma'am, you are conducting.
Coimbatore is a hotspot now, you know.
Okay,
for
yes,
COVID.
ma'am. Yeah, even though, ma'am, in this second wave, entire South is affected a lot, ma'am.
Yeah, and Tamil Nadu, Coimbatore is real red alert area.
Yeah, ma'am. Please take care, ma'am.
I know. I'm sitting in the hospital.
Okay. So, ma'am, you are conducting this symposium endometriosis across India, ma'am.
We are conducting, yes. Being the chairperson of the endometriosis committee.
Yeah, yes, ma'am.
That's what I have been doing throughout.
Okay, okay, fine, ma'am.
So last year we conducted many meetings.
Yes, ma'am.
And now again, yeah, I'm just trying to adjust this board. Deficit. Just trying to adjust my backdrop. Yeah.
Ma'am, you have to push it little more towards the right, the board.
Yeah, that's what I'm asking him to do. You can push it right, yeah.
Little more.
Little more. Some more.
No, that side. Your cupboard is in that side. Yeah, little more. Little further. Yeah.
No, you're holding it oblique now.
Fine now. It's fine now. Ma'am. It's fine now.
Something is still wrong.
Board is little tilty. If you could
Board
straight.
is tilted, I don't know why. Still, கொஞ்சம் ரைட் போடும். No, something is wrong today. நம்ம போட்டு இப்படி வைக்கணும். அப்போ கொஞ்சம் பேக்ல பாருங்க, பத்தல. See?
Ram sir, இன்னும் கொஞ்சம் push பண்ணுங்க. Correct. Further, இன்னும் கொஞ்சம் போதும். Fine.
Yeah.
Fine.
Okay, thank you. We are moving in opposite direction. ஆமா, அவங்க வந்து right who's right, nobody knows. So we are all ready.
And we are waiting for audience, ma'am.
Hello, Mr. Pankaj. How are you? Jyoti here.
Yeah. Very good evening, ma'am. I'm too good, ma'am. I hope you
All
are
fine.
also doing well, ma'am.
All fine. PPTs are all set in, right?
Yeah, yes, ma'am. Entire
Okay,
team
fine.
is there, ma'am, which is leading by Mr. Sirish. He's looking for my images, and all the technical support we will give it to you, ma'am. And
Yeah,
we are
thank
hoping each one of doctor will enjoy this program.
Okay. Thank you,
Very good
Mr.
evening, ma'am.
Yeah, very good evening, Sridhar, madam. Jai Sridhar, madam.
Good evening. Yeah, thank you. So the meeting might extend a little late, as madam had already mentioned, na?
Yeah, yes, ma'am.
It could extend to 7:30, or maybe it will finish on time also, but you never know.
No, ma'am, no issue, ma'am. We have a support with us. If it will last long more for 15, 20, 30 minutes, we will manage, ma'am.
Okay, thank you. So kind of you. Yeah.
Yeah, pleasure, ma'am.
Yeah. I'll go home and log in from my computer.
Yeah,
right,
please, ma'am. Please take care, ma'am. Please take care, ma'am.
Yeah.
Hi, Jayashri. Take care.
Hi, ma'am.
Hi.
Hello, ma'am.
Are you driving or a driver is driving?
I'm the driver.
She was driving, I hope so, ma'am.
Hi, Manisha.
Hi, ma'am. How are you?
I'm okay. Just going from OT, so I'll go home and change and just. I reminded Kavita, madam.
Should I call them?
Hi, Jayashri ma'am.
Okay, we unmute.
Good evening, ma'am. Jyoti here.
Good evening, ma'am.
Good evening. Hi, Anjali. Long time से met you, Anjali. Hi, hi.
Hi.
कैसे आप अच्छे?
बिल्कुल.
I said A for Andalib and A for Allahabad.
Oh, thank you so much.
Shirish, there is a pop-up regarding a start webinar.
So
Still we are in a practice
10
session.
minutes. Yeah, we have 10 minutes. So I'll just
We
start.
will also remind Dr. Jaydeep Malhotra.
Ma'am, she's logging right now.
Oh, okay, okay, great.
Good evening, Adliti.
Hello, ma'am.
Andalib and Chitra I met together at the Foxy meeting, managing committee.
Hi, Chitra.
Hello, Chitra. Yes.
Good.
And I think we organized this meeting over a very short period this time with Jayashri, Vritika, and Manisha. Shall we remind Kavita Bapat? Manisha, will you do that?
I'm calling her.
I've given a message to all of them today. Kavita and Fessy will join a little late, I think.
Kavita ma'am is logging right now.
Mm-hmm.
Calling others. Jaydeep ma'am just logged out and she's going to log in again now.
Okay.
Ma'am. Requesting please the speakers and chairpersons to rename themselves. They are logged in through the name of panelists.
Hi, Kavita.
Yeah, hi. This is Jaydeep here,
Hi,
Asha.
Hi, Jaydeep. Hi, Asha.
I'm not able to
welcome,
connect.
Welcome, Jaydeep. You are so prompt.
Asha, I'm not able to connect from my laptop. I think the email sent to me is, whatever the link you have sent, I'm not able to connect.
Okay.
So I'm.
Can Alembic do something about that?
We are sending some other link also, just in case. Ma'am, I have WhatsApp you.
Good evening, Kavita ma'am.
We also sent one to you by mail, Jaydeep. We thought it would be easy for you to join, the one with the mail.
So hi everyone. There I am.
Hi. Lovely. Yeah.
Good to see you.
It's like Devi Pratyakshvi. Suddenly, I was still looking at my WhatsApp and how to manage. Yeah, then there you are. Good.
Yeah.
Okay. Yeah. So now I think we can go. Kavita, I saw somewhere. Kavita Bapat.
Yes, I'm there.
Hi Kavita. Hi Anvi.
Hi.
All dear friends. Hi Ritu, Archana, Manisha, Vartika.
Hello, good evening, madam. Jaydeep ma'am, good evening.
Good evening, everyone.
Hello, Andalib.
Yeah.
Hello. Ma'am, how are you? Kavita ma'am, hello.
Hi Kavita, looking lovely.
Hi.
Lovely combination, Kavita. अरे पुरानी साड़ियां निकाल रहे हैं. I'll just log in 1 minute time. I know. कोरोना कम हो गया जयदीप मैडम आगरा में ना?
Yeah. काफी कम है. What a relief. I mean, we are able to smile now.
Yeah.
हमारा तो बुरा हाल हो गया था.
बुरी हालत, बुरे हाल, बहुत खराब. हमारे यहाँ भी ठीक है.
Yeah.
ट्रैवलिंग भी शुरू हो जाए तो अच्छा.
फिर कॉन्फ्रेंस भी हो जाए.
उसकी तो राह, उसको भगवान को प्रे कर रहे हैं ना अपन से.
Yes.
Archana ma'am.
Hello, Pragati. Hi. How are you?
Fine.
Hi, Dr.
Hi, Arjuna Dixit. Hi, Archana.
Hello, everyone.
I can see Archana. Archana, meet Dr. Jaydeep Malhotra, Dr. Kavita Bapat.
I have had the honor of meeting Dr. Jaydeep a few years back, and Dr. Kavita, lovely to meet you. Well, lovely to meet all of you. And thank you all for having me here.
Yeah, I mean, I wanted to have you for the previous meeting also, but somehow that couldn't do it. So very glad when you agreed.
No worries, always a pleasure.
You know, Coimbatore has become the hotspot for COVID now, my city.
Oh, is it?
Yeah, it's supposed to be the highest number of cases in Tamil Nadu now.
Yes, but I'm hoping overall India is kind of on road to recovery. It's been very, very stressful for us kind of listening to reports from there, I must say.
Yeah. My daughter is in Cardiff. She too is Archana. She's
okay. Yeah, I
she
think you
moved
mentioned
she moved out of gynecology into family practice. And
sensible girl.
Yeah. Hi, Vartika.
Hello, ma'am.
Vartika is all geared up and ready to welcome.
Yes, ma'am. Another 2-3 minutes to go.
1 more minute, right?
Yes, ma'am.
Can somebody just give a, of course, Nina's talk is after 20 minutes, so that's fine, I suppose.
Ma'am, I've told Nina ma'am, she'll be joining. She's just finishing her session, ma'am.
Okay. I think she had some exams going on.
Yes, ma'am. She wants to know what is her talk time, like at what time will her duration will be.
Her duration of talk is 20 minutes plus 5 minutes for questions.
And when will it start, ma'am? This is
yeah, if we start now on time, it should be at 5:25.
Okay, ma'am.
Jayashree, looking lovely now.
Thank you. Shall I just try sharing screen? Shall I just try sharing screen?
Yeah, do it quickly. Otherwise, you're going to start now in 1 minute's time. Yeah, we are all ready to start. Actually, only for my slides, which is at 6. Okay, so I'll call you at 6. Yeah, okay. And other slides for
Varadilla, can you see?
Yeah, Jaldi 1. Yeah.
Okay. Thank you. Stop share.
Hello, Jayashree madam. Good evening. Jyoti
Hi,
here.
good evening. Jyoti,
Nice.
you?
I'm not sharing the screen.
Okay, okay. I can see Manisha, Pragati, Vartika. One in magenta dupatta is Vartika, no? Your Vritika or Vrartika?
Vartika. So now that we have the chief guest and the speaker and the chairperson, shall we start the meeting?
Yes, ma'am.
Yes, ma'am.
Otherwise, we keep losing time. Jaydeep is here, Archana, Kavita, Andalib, all are here. Yeah. Manisha, if possible, give a call to Dr. Arun Boruma.
Okay, okay, ma'am.
Or a message. But I think we can start in the meanwhile.
Yeah, he's in the second talk. No?
I've already messaged to sir and given him the link, madam.
No, he's in the first talk.
Yeah.
But Kavita is here, but because of this Figo and Origine, I think there is some sort of Mr. Pankaj, shall we tell everybody and start after a minute?
After 5 minutes? Sure,
1
ma'am.
minute.
Sure.
1 minute.
After
1 minute.
Fine, ma'am. We
We're
will
all
start
ready
the
because
program.
yes.
Yeah, yes, ma'am. We will start the meeting after 1 minute. We are ready.
Yeah.
Shirish, am I right?
Yes.
Yes.
Yes, sure.
Dr. Arun sir will be joining in a couple of minutes. Sir.
Fine. So now I think we'll all get ready to start, go live.
Yes, Pankaj. Let's start.
Yes, we are live now.
Yeah.
So, ma'am, should we start?
Yeah.
Yes.
Fine. Very good evening, all doctors. I am Pankaj Sahu, Zonal Sales Manager, Alembic Pharmaceutical. On behalf of Alembic, today I am here to welcome all respected doctors for the Symposium of Endometriosis, a disease which is affecting irrespective of age group. Dear doctors, you have been aware that Alembic has always been at the forefront to organize scientific academic meetings. So today we are also glad just to be part of this quality program. We are very much sure that you all doctors are going to enjoy, learn so many of things with this quality program. So for further proceeding, I would like to introduce Dr. Vartika Kishore. Dr. Vartika Kishore, she is a MBBS MD doctor. She is a consultant at Vrindavan Arogya Deep Hospital, Vrindavan, Mathura, UP. She is a past president of Mathura OB-GYN Society. She is also executive member of FOXY IAEC 2021-22. She is an executive member of SMF UP chapter, as well as she is also advisor of Adolescent Health Committee, SMDHM. She's having a special interest in preventive oncology, high-risk pregnancy, adolescent health, infertility, and ultrasound. A part of Dr. Vartika Kishore, I also would like to, it is my pleasure just to introduce Dr. Manisha Singh. She's a MBBS MD obstetric and gynecology, and she is a senior resident doctor in OB-GYN Trauma Center, BHU, Varanasi. So, ma'am, Dr. Vartika, I would like to request you just to handle this session, this meeting for the further proceedings. Dr. Vartika.
Thank you so much. Good evening, everyone. Greetings from Mathura. I thank Dr. Asha Rao Mam to give me this opportunity. This is yet another series in Pan-India Endometriosis Symposium. Today, we have OB-GYN societies of Varanasi, Mathura, Bareilly, and Allahabad with us. We have wonderful sessions ahead with very, very knowledgeable experts. As we have sessions, you will really enjoy. To begin this session, I would like to introduce Dr. Asha Rao Mam. Dr. Asha Rao Mam is the chairperson of Endometriosis Committee FOXY 2020-22. Ma'am has 25 years of experience in ART. She delivered first ICSI baby of Coimbatore and is director of Rao Hospitals and Care, Coimbatore. She is the director of postdoctoral fellowship program in reproductive medicine and endogyny. She has been past president, Coimbatore Obs-Gynae Society. Ma'am has organized many conferences as chairperson, like Endocide this March, Yuva Foxy South Zone, IAGE Star Endogyne Conference, and National ISAR Conference. As a chairperson Endometriosis Committee, she is doing tremendous work and conducted many webinars. And besides this academic introduction, she's a very affectionate person, and I thank once again to give me this opportunity. We also have with us Dr. Jayashree Sridhar Ma'am. She is presently a senior consultant at Indore. She's done her graduation from KMC Chennai and PG from MGM Indore. She has been trained from Germany in reproductive endocrinology and has special interest in evidence-based medicine. Now I request Dr. Asha Rao Mam to introduce our eminent guest of honor, Dr. Jaydeep Malhotra Mam from Agra and Dr. Ramani Devi Mam. Dr. Asha Rao Mam, please.
Thank you, Vartika, for those nice words. And at the outset, let me welcome all of you to this prestigious meeting of Pan-India Endometriosis Symposium, along with societies of Uttar Pradesh, that is Varanasi, Mathura, Bareilly, and Allahabad. I have been waiting to meet all of you here. And all of us know that endometriosis is increasing in incidence, and world over 176 million women are suffering from endometriosis. Of these, 25 to 30 million are in India, and it really brings down the quality of life in women. So it's very important that we spread the knowledge of the right ways to diagnosis and right ways of management in women with endometriosis and adenomyosis. And that's how we are doing this Pan-India Symposium on endometriosis and adenomyosis throughout the year. And it's also a privilege as the chairperson of Endometriosis Committee. And today I'm very glad that my dear friend, Dr. Jaydeep Malhotra, is here as the guest of honor. Jaydeep is known to me for so many years, and she is known to everybody, not only in India, outside India also. She has been past president of FOXY. She is the director of ART Rainbow Clinic IVF, president Indian Society of Prenatal Diagnosis and Therapy, president South Asian Federation of Menopause Societies, immediate past president ISAR, past president of Aspire also and Indian Menopause Society, regional director of South Asia Iron Donor School of Ultrasound, Professor Dubrovnik International University, Croatia, editor-in-chief of Suffolk and Suffolk's journals and many books. She's such an affectionate, warm person, and she has credited with first 500 IVF babies of Nepal. They started IVF in Nepal, Jaydeep and Naren together, and she's a recipient of very many awards, and she has chaptered so many books. We are very glad to have you with us, Dr. Jaydeep. I welcome you as the guest of honor to our meeting, and I request you to give us an inspiring address.
Thank you, Asha. Thank you so much. It's such a pleasure to be with all of you. I think this pandemic has really given us enough opportunities to be together. But apart from being together, I think academics has been on top in the last 16 months, what we have seen, and especially with good attendance. And in fact, just yesterday, somebody I was talking to and was saying, Madam, how much we have learned in these 16 months is beyond any comprehension, whether it is about the disease or it's about our OBGYN. And I feel when our Prime Minister says, you seek opportunities in all kinds of troubled periods and challenges, this has come out as a great opportunity. My heartiest congratulations to you first, Asha, for doing some wonderful work. And what I really appreciate is that apart from a good program, bringing in people together, bringing in societies together, and we have learned now to save our energies and connect with as many people as possible, and plus involve people, because that's something which is very, very important, because once you involve people, being inclusive is another very important thing. Today's World Environment Day, and this is something which is, again, we know that there's a huge connection between the endocrine disruptors and endometriosis. And that is, again, something I would really wish somebody would definitely highlight, because there is so much this enigmatic disease has, inside its own womb, hidden so many facts which we don't know, why it happens, what is the right treatment. It is involving from adolescent onwards to menopause. The treatment varies differently. Infertility is the only one of the problems which, one faces, and getting somebody with endometriosis or adenomyosis pregnant is a huge challenge. And again, maintaining the pregnancy is again another challenge. And I see in the program that a lot of things are being covered. This is something which has been very close to my heart. And I see that a lot of lovely academic people are involved here. And I'm sure the audience is also going to be gaining a lot from this deliberation. One thing I'd like to also add on, that I am there in the Reproductive Medicine and Endocrinology and Infertility Committee of FIGO. And in fact, on the 7th of June, just 2 days from today, at 8 p.m., we are starting a master class on endometriosis. That is FIGO's master class on endometriosis, where the opening lecture is going to be from none other than Linda Judice. She has been the past president of ASRM and current president of IFFS, and has done tremendous work on ADCs and endometriosis. So those of you who are listening to me, do join us. It's a series of 6 lectures, one every month, by the top people of the world who are going to be there, and you're going to get certified also at the end of the series. So with these few, little informations, I wish you all the best, great deliberations, and again, heartiest congratulations, Asha. Keep on doing the good work. I'm absolutely thoroughly impressed. Ramani had done a great job, and you have really followed it up. And I know that our next vice president who's sitting here, very dear friend Kavita, I'm sure you're going to, take this forward. And Ritu, again, congratulations. You're doing very amazing work in this region. And all of you panelists and the young people, Manisha, I mean, you rang up a number of times, and this dedication is something which is going to take all of you forward. So all the best to each one of you, Vartika, Manisha, and everyone else. This is one disease where you need to really understand and then treat well. So I'm sure we're going to gain a lot, and I'm also looking forward to it. God bless you.
Thank you, Jaydeep, for those warm, affectionate, inspiring words. And we all really feel energized by your address. Now I also welcome our eminent faculty, Dr. Arjuna Dixit, Dr. Nina Malhotra, and I think we are missing out on Dr. Ramani Devi, who is other guest of honor. Ramani has been a tremendous support to me throughout the year, and she has also done humongous work on endometriosis. But since she got held up with some meeting, she's unable to join. Are you here, Ramani, by chance? I don't think she's able to join.
But she has sent one video also to be shared. She has for, as a guest of honor. I have sent it to Shirish Jain, so yeah, we can play.
Okay. Yes. I also welcome Dr. Kavita Bapat, the incoming vice president, and Dr. Fesi Louis, the incoming vice president, and our chairpersons, Arun Barua, Andaleep, and my co-moderator, Ritu Khanna. Yeah. Let's have this small video.
Yes. Yes, Vaishnavi, if you can share.
Yes.
How many minutes is that?
It's 2 minutes now. Vaishnavi, audio is not.
Audio is not there. Just give it a minute. There's an option called share screen with audio. If you check. Take 1 second. Just.
Pan-India Endometriosis webinar.
Is it audible now?
It is audible.
Along with the obstetric. Good evening, friends. On behalf of Foxy Pan-India Endometriosis webinar, along with the Obstetric and Gynec Society of Mathura, Varanasi, Bareilly, and Allahabad, I have immense pleasure in being a guest of honor for this very important webinar. Along with me is Dr. Jaydeep Malhotra, a giant in this particular field. I am really honored to share the dais with her. I congratulate the organizer, Dr. Asha Rao, who is again a very, very leading personality in the field of endometriosis in India. And also, I am happy to have Dr. Jayashree, Dr. Neena Malhotra, Dr. Arjuna Dixit as speakers, and there will be an excellent panel discussion which will be participated by Dr. Fesi Louis, Dr. Arun Barova, Dr. Kavita Bapat, Dr. Andalip Agarwal, and Dr. Ritu Khanna. So there will be a Jaldi 5 program for which Dr. Jayashree Sridharan is very fond of, and I wish this particular webinar will throw lights regarding the facts about endometriosis, especially in the COVID period, and I wish the organizers happy to be a part of this webinar, and I congratulate the organizers, chairpersons, faculty, and all the participants as well as the societies involved. Grand success. Thanks for the opportunity given.
Yeah, I think it was a lovely video. Thank you, Ramani. And yeah, Vartika, kindly
Yes.
take.
And now I invite Dr. Jayashree Mam to introduce our chairpersons for our first session on adolescent endometriosis, dilemmas and dispute by Dr. Arjuna Dixit Mam. Dr. Jayashree Mam to please introduce our chairperson, Dr. Kavita Bapat Mam and Dr. Arun Barua sir.
Absolute pleasure to invite our own Dr. Kavita Bapat from Indore. She's incumbent vice president for 21-22, and all of you must know she's won by record margin. So we are so proud of her. As it is, she's a very, apart from all her, huge achievements, I must say in Indore, she's one of the most friendliest gynecologists, and the go-to person kind of a person. Like, you don't mind picking up the phone and talking to her at any time, even though she's so many years our senior. So she has been organizing many. Her BreastCon was a huge success, and she's had a lot of Nari Samanaika award from the this thing. I remember her a lot of news presence in that also. And then she's now on her special interest is on premature ovarian failure, and she's also started a registry which we need all your cooperation to make it a huge success. And she's a one-day hysterectomy specialist, and she's a governing council member of ICOG, past president of Lions Club. And yeah, she has huge, Kavita madam, welcome. It gives me great pleasure in welcoming you to this webinar, or the very important session. And Dr. Arun Barua, can I have his slide, please? Oh, welcome, Dr. Arun Barua. You are the co-chairperson with Dr. Kavita Bapat. It's going to be a scintillating session. He's a consultant gynecologist from Sampriti Hospital in Shirsagar in Assam, chairperson of the Northeast ISAR and Northeast Chapter IAG, and he's the best branch president of IMA. So that speaks hugely of his administrative capabilities as well. Welcome, Dr. Arun. Yes, Kavita Bapat, madam, and Arun Barua, the stage is yours.
Kindly put Arjuna Dixit's CV, please. Arjuna Dixit, thank you so much. Thank you so much. Nice introduction, Jayashri. First of all, I'd like to congratulate Dr. Asha Rao for doing this pan-India endometriosis, this seminars, and especially today's with so many North Zone societies. So congratulate Asha. And first, my regards for Dr. Jaydeep Malhotra and Dr. Ramani Devi. One word for Jaydeep Malhotra, I have evolved whatever I am today is looking after her. She is the most darling person. And the important thing is that the endometriosis is a leading pathological cause of dysmenorrhea and chronic pelvic pain in adolescent. And the appearance of endometriosis is different for the female adults, results into the delayed recognition and intervention. But what I feel, the delay in diagnosis can cause so many things: persistent pain, bad quality of life, potential progression of the disease, and so many things up to infertility. So it should be tailored. Individual adolescent treatments is needed for the endometriosis. And today is basically the environmental day. So reimagine, recreate, and restore is the thing. And I'm really happy to introduce Dr. Arjuna Dixit. And she is a graduate in India in 1993, and she is from Lady Hardinge Medical College, New Delhi, completed MD in 1998. And she has worked in Muscat, Oman, and in London. Now she's in London. She was the first Indian doctor from overseas awarded gold medal in MRCOG UK and trained in Northeast Thames region with a trained under the eminent Dr. Sinu Vichubai. She is presently consultant and obstetrician and gynecologist at Chelsea and Westminster Hospital, London. Dr. Archana is also honorary senior lecturer at Imperial School of Medicine, London, and nominated by her patients for the prestigious Asian Women Achievement Award. So Dr. Archana Dixit, it's over to you for the adolescent endometriosis.
Thank you so much, Dr. Kavita. Thank you for your very kind introduction. I would also like to start by thanking Dr. Asha Rao for inviting me to be a part of this, this eminent webinar. And it's really very, very delightful for me to see the shared passion all of you have for spreading awareness of this, this disease, which can be quite debilitating for most women. And also we are all aware that many women suffer in silence. So it's really very important that as many of us as can spread the word around about what this disease is all about, it really matters. I think it's also very lovely to be in particularly a part of this webinar, which has been, of course, organized by Dr. Asha Rao. But I was delighted to see that a lot of obstetric and gynecology societies from Uttar Pradesh are involved in it, because, you know, I think through my introduction, none of you will probably know that I actually belong to Lucknow. Although I've not done any of my education there, but of course it's very close to me, to my heart. You know, Lucknow and Uttar Pradesh will always have a special place in my heart. So that's another bonus to be part of this session today. I, of course, many thanks for the chairpersons and the guests of honors. It's really, you know, all of you are such eminent gynecologists. And I think, you know, although the last year and a half has been so hard for us with COVID and its ramifications, but in some ways it has also brought us all together through these Zoom, Microsoft Teams webinars, where we all have connected and learned and shared all of our experiences so much more. So anyway, I think I'm sure you're all more interested in listening to what I have to say on adolescent endometriosis than other things, so we will make a start. Let me try and share my slides. Okay, I think I might need to. Okay, I hope all of you can see that.
Yes.
So, of course, Dr. Asha had given me the topic of adolescent endometriosis. And I thought, I would start by saying that it truly is an enigmatic disease. I think some of you mentioned the word enigma. And it has been a subject of debate. Endometriosis in itself has been a subject for debate in all relevant gynecological circles, and adolescent endometriosis, if anything, is not an exception, but probably even more of a subject of debate. The controversies, the dilemmas, the disputes or debates which commonly relate to, but are by no means limited to its prevalence, disease course, and the best treatment options are well known to all of us. Majority of the questions are surrounding it still remain unanswered. And most of the responses we get are probably still very opinion-based rather than evidence-based. But why is it important? Why are we so worried about endometriosis, particularly in adolescents? We all know it's a chronic condition. And we also know that many clinicians are less familiar with diagnosing it and dealing with it, particularly in this age group. It does have a significant impact on the lives of adolescent girls, particularly their quality of life, even if we don't talk much about the medical effects or the symptoms of it. It has a great impact on their functionality, and many of them will avoid, going to school, avoid exercise, avoid activities. In the more and more growing world of adolescents being involved in social life, there is so much social media and they have so much interaction with each other that it definitely has a big negative impact on their social life and leads to loss of confidence. Of course, we don't need to emphasize too much on the psychosexual impact it has on these young girls as well. And very often the diagnosis, particularly in this age group, is delayed, leading to suffering and disease progression. So what are the, so I was given the topic dilemma and disputes, I think. I think all of you will agree that in the medical fraternity, there's never any dispute. We don't dispute anything, we debate things. So I thought I'll just change the topic a little bit to say dilemmas and debates. While one can talk a lot about endometriosis, and particularly in this age group, I thought I will limit myself to what truly might be the debates surrounding this topic and try and cover those more. So some of the debates which we know are, well, is it a rare disease in the adolescent age group, or is it quite common? Do most of these individuals suffer with early stage disease, as classified by the American Society of Reproductive Medicine, that is stage 1 or 2, or can they have more advanced disease? Is it a progressive condition, or is it actually self-limiting, even if it is present? When should we perform a laparoscopy? What should be the best mode of treatment? Is it surgery, or should it be medical management? If surgery, should we go for conservative surgery, or should we go for radical surgery? Is it a disease with a lot of recurrence? What are the recurrence rates? And what is the opinion on the long-term use of suppressive hormonal medication? So all of these are things I'll try and cover in my talk. So as I've said before, it is a chronic condition, and many people, particularly in the country kind of I'm working in, most of the people will initially be accessing their general practitioners for any symptoms. And while gynecologists may be familiar with this condition, most of the GPs may not be very familiar with the subtle signs of this condition, particularly in the adolescent age group, and hence diagnosis and management may be delayed and also pose quite significant challenges. There have been symptomatic cases reported even prior to menarche, and even as soon as 1 month after menarche, which does lead some credence to theories other than the Sampson theory of retrograde menstruation, which is the most popularly believed reason for endometriosis. But finding endometriosis in these young girls even before menarche suggests that there may be other ways that the condition can present, which is stem cell and coelomic metaplasia. There was a registry of 4,000 adult women with endometriosis, in which 2/3 of them reported that their first pelvic symptoms occurred before 20 years of age. and 1 in 5 of them had pain before the age of 15 years. So one of the controversies is, well, how prevalent is the condition? Is it rare? Is it common? The true prevalence, even in adult endometriosis, is unknown, and reported figures are based mainly on estimates rather than true values. In particular, in adolescent age group, this is even less clear as to what is the exact prevalence. As we all know that many cases may be asymptomatic or have atypical presentations, and classically it is diagnosed on laparoscopy, either by visual inspection or on biopsy. And because it seems, of course, the laparoscopy is performed more in the symptomatic population, so automatically a selection bias gets introduced in it. So difficult to predict the true prevalence. However, there are studies which have estimated that 25 to 38.3% of adolescents with chronic pelvic pain do have endometriosis. Janssen et al. In 2013 did a systematic review, and they found that overall the prevalence of visually confirmed endometriosis was 62%, ranging from 25 to 100%. In their in their review, they found that laparoscopically confirmed endometriosis in 880 young girls with chronic pelvic pain or dysmenorrhea, the prevalence was calculated as varying from 49 to 75%. What are the risk factors for the condition? So a positive family history seems to be a very strong risk factor, and systematic genetic studies of 123 confirmed cases showed that the rate is as high as 6.9% in first-degree relatives, as opposed to only 1% in the relatives of controls. Other case series have reported a much higher genetic link of 25 to 30%. Of course, the genetic link is not very clear and is likely to be multifactorial in terms of the genetic predisposition. Ethnicity plays a crucial role, and we know that white, Caucasian, as well as Asian women are more prone to develop endometriosis. And I certainly in my practice here see a lot of young Indian girls, along with, of course, the young white girls which present with this condition. As opposed to Hispanic and Black women who have this condition less often. Early menarche and low BMI, and of course the obstructive Mullerian anomalies which lead to retrograde menstruation, such as imperforate hymen, transverse septum, vaginal agenesis, are all linked to the presence of endometriosis. There seems also to be a link between childhood sexual or physical abuse and the presence of, or diagnosis of adolescent endometriosis. So what is the clinical presentation? Of course, as endometriosis in the older woman, it also tends to present with pain symptoms. However, the pelvic pain may be rather atypical in these young women and tends to be more acyclical or non-cyclical pain or chronic pelvic pain, as opposed to the adult women where it is more likely to be dysmenorrhea. However, they can present with dysmenorrhea, which can be secondary or primary dysmenorrhea. Bladder symptoms, amongst the atypical symptoms, bladder symptoms mainly of an overactive bladder, such as dysuria, urgency, bladder pain, are also quite often the presenting symptom. Gastrointestinal symptoms, particularly those like IBS type of symptoms with alternating diarrhea or constipation, painful passage of stools or dyschezia is also seen not infrequently. And again, these atypical symptoms are why sometimes the diagnosis is delayed. These young girls can also present with pain on exercise and pelvic muscle spasm. So they often present to physiotherapists for, when they are going through these pelvic muscle spasm syndrome, and people don't recognize that this could be because of underlying endometriosis. Other pain disorders seem to be more common in these young ladies as well. And that is probably because of a central sensitization to pain. And these women can also present with severe migraines, headaches, fatigue, fibromyalgia. Of course, in the sexually active young women, they may present with dyspareunia, which can be deep and or positional. Endometriomas and infertility are naturally less frequent in this young population. And as I've alluded to before, its negative impact on quality of life and functionality. And sometimes, the only indication might be that these young women are forever avoiding exercise, and particularly missing school days where they need to be physically active, so missing activities at school. So, well, what is the natural history of the disease? There again, there is more kind of dilemma around this, and there are conflicting reports. Earlier reports suggested that adolescent endometriosis almost exclusively was early stage disease. As I've mentioned, stage 1 or 2. And many studies proposed that was what it was. In particular, the systematic review by Janssen et al. Found that 50% of the teenagers had minimal disease, 27% mild, 18% moderate, and the rest of them had severe disease. This was in 8 out of the 15 studies they looked at, because these were the only studies which had included the stage of the disease and used the revised ASRM staging technique for diagnosis of endometriosis. So of course, there are limitations to the older studies. However, later studies have suggested that there is a much higher proportion of advanced disease in these young women, including deep endometriosis and the presence of endometriomas. So I won't go through all the studies. Of course, they're all there if you would want to have a look at them later. But it would appear that all stages of endometriosis are found in teenagers also. And teenage or adolescent endometriosis is not just limited to early stage, although, of course, they are decidedly more common early stage disease as opposed to advanced endometriosis in these women. Well, the other subject of debate then is, well, what is the natural course of the disease? Is it self-limiting, meaning does it undergo spontaneous regression? And a prospective randomized controlled trial by Hans et al. In 2013 showed that 42% of lesions might spontaneously regress, especially if they were superficial lesions. This RCT included repeat laparoscopies with at least 6 months interval to make this conclusion. And progress of the disease was seen only in 29% of the women. However, others say that no, it is not a self-limiting condition, but it is progressive disease and leads to long-term, advanced endometriosis if it is not managed during adolescence. And the French data in 2015 suggested that the initial diagnosis was of 6 deep endometriosis cases. However, repeat laparoscopy showed that 9 more had developed deep endometriosis. And 3 of the original 6 patients who'd been treated at the time later developed recurrent deep endometriotic disease. They also found 5 new cases and 7 recurrent endometriomas in the follow-up period. So certainly it seems like it might be a disease which progresses. But once again, this is a subject of debate, and I don't think we have concrete answers as yet. It does seem like deep endometriosis might have its roots in adolescence, and in the long term, the adolescent endometriosis progresses to deep endometriosis. So how do we diagnose this condition? Well, of course, the symptoms and need for a high index of suspicion in young women presenting particularly with atypical symptoms. A comprehensive history is very important. And of course, if one is not aware of what to seek out in the history, then the diagnosis automatically becomes difficult. It is can be quite helpful to ask women to maintain a pain diary, to check for the frequency of pain, the character of pain, the provoking factors, particularly is it around menstruation or bladder or bowel movement, can be quite highlighting. The persistence of pain, particularly despite being on the combined pill or the use of non-steroidal analgesia, should also point towards the diagnosis of potential endometriosis. Atypical symptoms, the bladder or bowel symptoms I alluded to earlier, of course, one would need to exclude other causes for those symptoms, but they are not uncommon in adolescent endometriosis. Examination. The goal of the examination is to rule out a pelvic mass or a reproductive tract anomaly. A rectal abdominal examination might be better tolerated in these young women, particularly if they have not yet initiated sexual activity. If one is wanting to exclude a Mullerian tract abnormality in these young girls before sexual activity, a Q-tip swab can be quite helpful in assessing for the vaginal length and patency. Imaging probably does not have much role in diagnosing endometriosis in these young women. However, of course, it is used to exclude, for instance, pelvic ultrasound can exclude other things like an ovarian cyst, or of course, endometriomas, a pelvic mass, adnexal torsion, or a Mullerian abnormality. MRI scans, again, very infrequently will pick up endometriomas or deep infiltrating disease, but usually the ultrasound scans or the MRI may come back normal if it is stage 1 or 2 disease confined only to the peritoneum. If appropriate, of course, one should also consider doing pregnancy tests and an STI screen and a urine analysis if need be. However, there are no specific blood tests or markers which diagnose endometriosis. And while we are all aware of the CA125, we also know that it is a very non-specific marker and is not useful at all in either diagnosing endometriosis or to monitor the disease progression. So laparoscopy, of course, it is the gold standard for diagnosing endometriosis. We all know that. However, the debate here is, well, how soon should you do a laparoscopy in the adolescent population? Should it be the first thing to make the diagnosis, or should you only proceed to it after failed medical therapy? Of course, the diagnosis, it should always be done for the latter condition. So if the person has failed to respond to medical therapy or become resistant to medical therapy, then you would proceed to a laparoscopy. And of course, if you're considering surgical management, then the laparoscopy is indicated anyway. We all know that medical therapy is not going to treat adhesive or deep disease as appropriately as the early stages. What is key with the laparoscopies, particularly in the adolescent population, is that it should be done by a skilled surgeon who is trained to recognize the subtle lesions of these early stage endometriosis, as they can be quite different in the adolescent population, where there is a predominance of clear and red lesions as opposed to the powder burn lesions or the chocolate charred lesions seen in the adult woman. Some techniques which can be utilized during laparoscopy are one called the closed tip technique, where the laparoscope tip is taken very close to the peritoneum to skim over it and be able to identify particularly the clear vesicular lesions. The other is to submerge the laparoscope in a lot of irrigation fluid left in the pelvis, which also highlights the vesicular lesions much more. If, despite doing a careful laparoscopic assessment of the peritoneum, no lesions are identified, then it is suggested by many that we should take random peritoneal biopsies, as histologically it might come back as endometriosis. So as I mentioned, the lesions can be quite subtle, and the larger picture shows the subtle vesicular lesions in a young lady, whereas it is the classic powder burn lesion in the adult in the smaller picture to the side. The clear vesicular lesions, I hope many of you get reminded of chickenpox lesions on the skin when we look at these, and if not carefully assessed for and not actively looked out for, one can easily miss them on laparoscopy. Hemorrhagic lesions, the red lesions, are also more common in the adolescent population. And the peritoneal windows are also a type of lesion which is more commonly found in early stage disease, and once again, can be missed if not looked for actively. So what I like to think is, just like the young ladies, the disease is also young, and like these young women are flowering and budding, the disease is also flowering and budding and more active or florid. It is also more metabolically active and produces greater prostaglandins. Hence, despite the paucity of lesions which one may see, the disease can be quite advanced in terms of its metabolism and give rise to a lot more pain and inflammation. So the symptoms may be far more advanced than what one sees at laparoscopy. Right, well, what is the treatment for the condition? So treatment in terms of the medical armamentarium we have, one can start with non-steroidal analgesia. Of course, we are all aware of the estrogen progestin therapy in the form of the continuous combined pill, the progestin only, either as the progesterone only pill or norethindrone acetate, to which these young women respond quite well to. The depot injection is probably not very widely used in these young population because of its negative impact on bone mineral density. And if one were to consider using it for some reason, ideally it should be done at the age of 17 or over, but will not certainly be our first choice. The Implanon seems to work quite well, as does the levonorgestrel IUS or the Mirena IUS. However, again, insertion of a Mirena in young women before sexual activity might not be the best thing for them. However, if one is proceeding to a laparoscopy, that might be something quite worth considering to insert at the same time. Other treatment options such as GnRH agonists may have their use, particularly if the young woman has been non-responsive to the first line treatment. However, again, because of its impact on bone mineral density, it has to be with add-back therapy. Some other treatments which are rarely used would be GnRH antagonists, and methyl testosterone, danazole, because of their side effect profile, may actually come in handy in the transgender population because they welcome these side effects, which kind of give them more male pattern characteristics. So surgical treatment, again, controversy surrounds the surgical treatment. I've already talked to you about, the controversy around whether laparoscopy should be the first line or laparoscopy should be done if failed medical management. So should surgery be avoided as much as possible to avoid multiple operations in the future? Or should surgery be considered in early stage before severe lesions develop? I think no one truly knows the answer to that, and we have many opinions, but probably not much evidence to suggest one way or the other. If one is performing surgery can be a few different types. Of course, laparoscopic surgery is the one which is preferred, and it may be adhesiolysis or ablation of endometriotic deposits, or indeed excision of the endometriotic deposits. And again, there is a lot of controversy on which one is better. And probably in stage 1 and 2 disease, there is not much difference in pain relief, whether you ablate the deposits using either electrocautery, endocoagulation, or laser, or you excise the deposits. There is really no real data to support radical excisional surgery or peritoneal stripping for such early stage disease in young women. However, some groups have reported a good response to excisional surgery and prefer doing excisional surgery over ablation. What about recurrence? Does one need to put these women on long-term suppressive medical treatment in the hope to prevent recurrence of symptoms and reduce disease progression? There is again conflicting evidence on actually the recurrence rate after surgery, and while some groups have suggested that there is almost 56% or very high recurrence rate after surgery. So for instance, Tandoy et al. In 2011 on a 5-year follow-up of 57 women under the age of 22 years, suggested that 56% had recurrence of disease. However, only 34% of these were confirmed laparoscopically, and 66% were only based on symptoms or ultrasound scan findings. There are other groups, though, for instance, Young et al. In 2011, who supported that there was no visual or histological evidence of recurrence in 8 of 17 teenagers who underwent repeat laparoscopy within 66 months after surgical treatment. So that gives that 47% of them did not have any evidence of recurrence. So while the earlier group suggested that all the patients after surgical therapy should be advised to take medical therapy, these young adults questioned the place of postoperative hormonal maintenance treatment in these young women. So I think the jury is still out as to what should be the best way to manage them. But my personal view is that more and more of us are of the opinion that putting these young women after surgery on suppressive medical treatment does prevent recurrence of symptoms and reduces disease progression to advanced stages of endometriosis in adult life. What about alternative therapy? Of course, we as physicians, as gynecologists, talk a lot about the medical treatment and surgical treatment. However, there is some role of complementary therapy. Along with complementary therapy, of course, clear explanation of the diagnosis and the condition also is quite helpful for these young women. Some of the other treatments which might help is an advice for them to keep active with gentle exercises, and it's been seen that there is a reduced pelvic muscle spasm, and resting too much actually worsens the pain, whereas keeping active and doing gentle exercises such as walking or stretching is more beneficial. So if they can be gently encouraged to do these exercises, it seems to have a positive impact. With the pelvic muscle spasm, if they are undergoing physiotherapy, it's quite important that the physiotherapist is a specialist women's health physiotherapist who can guide them through the appropriate exercises. Improving diet, such as increasing the intake of water, fibers, and reducing complex carbohydrates is also helpful. Pain distracting activities and developing interests which take them away from constantly thinking about their pain and the condition and the cycle of chronic pain also is useful. So are mindfulness meditations. Of course, use of a hot bath and hot water bottle. Hot water is a great analgesic. There have been some studies done on acupuncture, and a systematic review showed that acupuncture is quite a useful treatment for this condition in particular. And the Japanese style endometriosis and acupuncture has been shown to be a safe, effective, and well-tolerated treatment option in a randomized sham-controlled trial in 2008. I was quite intrigued to learn a bit more about the Japanese style acupuncture, and it seems like, as opposed to the Chinese style acupuncture, they use shorter, sharper needles and do a more gentle and superficial insertion of these needles, and then quite often use moxibustion in conjunction with it, and no herbs, as opposed to the Chinese, who are a big fan of herbs. So that might be well worth considering, and certainly doesn't seem to cause any harm. So to wrap it up, there is still a lack of level A evidence for adolescent endometriosis and its management. Level B evidence suggests that adolescents present with acyclical pelvic pain or non-gynecological symptoms. Surgical management does seem to improve pain. It goes without saying that it is a chronic condition without cure. And hormonal treatment does suppress regrowth and possible disease progression. There is level C evidence, which suggests that failure of empiric medical management should definitely lead to laparoscopy. Ablation or excision can be performed. However, radical excisional surgery or peritoneal stripping should be avoided. And that is mainly to avoid, scarring, adhesion formation, and the lead up to subfertility in the future. If a trial of the combined or progesterone-only pill or GnR has failed, then GnRH analogs can be considered with add-back therapy to reduce bone mineral loss. However, of course, this will also be relatively short-term. So, well, this is where I am. And the two hospitals which I've shown in the corners are my workplaces. So the top right is the Chelsea and Westminster Hospital. So my trust has two hospital sites, the Chelsea and Westminster Hospital at the top right-hand corner, and the West Middlesex Hospital, which is where I'm mainly based, is at the bottom left corner, and the backdrop of the beautiful London city. So that was a whistle stop through adolescent endometriosis, and I'm sure it's kind of hopefully raised more questions than answers, but that's what it is all about. So I'm ready to take any burning questions. Thank you.
Thank you, Dr. Arjuna Mam, for explaining dilemmas and enigmas of adolescent endometriosis so nicely and simplifying many of our doubts. I request Dr. Arun Barua sir to please give his comments. Dr. Arun Barua sir, are you there?
Thank you so much, Dr. Asha and your team, for inviting me for this magnificent update program on endometriosis. And Dr. Dixit has really highlighted everything about the adolescent endometriosis. So I'd just like to add a little longer, because we in this part of the country have a lot of myths that really go by late detection of the disease as it is across the globe. But the duration of this delay in diagnosis is manifold in our country. The studies have been proven from north to south and east to west that in our own country, there's a delay to the maximum of 9 to 11 years on an average. And that's how we presume the disease has invaded, much beyond that could have been prevented if it would have detected early. So that's one area, and a lot of awareness needs to be taken around, especially in the school-going children and to the moms, that any pain, whether it is cyclical or acyclical, could be endometriosis, and thinking of endometriosis has to go around, else these girls will end up in stage 4 endometriosis very soon. She has rightly pointed out there is no evidence-based robust grade 1A recommendation for a treatment of endometriosis, especially in adolescent, but obviously taking everything into consideration, medical management is the preferable way forward. And today, we all know we do not take up surgery even in a girl or a woman who has been diagnosed with endometriosis as a first line of therapy, until and unless there is definite need to go for it. So really, thank you, Dr. Dixit. I think you have highlighted every part of the disease process. And my personal take on a special mention from this forum to everyone, those who are tuning in, would be, please create awareness and please be friendly with your surgeon colleagues to make it a point that whenever they treat a girl for appendicectomy, let it be through a laparoscopic route so that it helps in a precise diagnosis, not that they just remove the appendix without touching the disease process and they come back with a more aggressive disease subsequently. Thank you so much for asking me to join, and really it is nice to see the friends again on this pandemic days through these webinars. Hope to meet you everyone in person very soon. Thank you, Asha and the team.
Thank you, Dr. Barua, for this wonderful comments. Dr. Archana, it was a lovely lecture. And I myself have lots of questions for you. But what we'll do is we'll wait until Dr. Neena Malhotra also finishes a talk, and we'll take both the questionnaire for both the speakers together. Thank you so much.
That's great. No, thank you, Asha, and thank you, Dr. Barua. I think
please stay back with us, Archana and Dr. Arun.
Yeah, sure.
Yeah, Vartika, could you please introduce Dr. Andalib and
yes, ma'am.
Dr. Fesi quickly?
Yes. After this wonderful session, next topic for today is optimizing ART in endometriosis by Professor Neena Malhotra Mam from AIIMS, New Delhi. To chair this session, we have Dr. Fessy Lewis sir and Dr. Andali Agarwal ma'am with us. Dr. Fessy Lewis is a renowned personality of Foxy. He is Foxy Vice President-elect 2021, ISAR National Executive Member, Vice Chairperson, Kerala Chapter IAG, ICOG Governing Council Member-elect 21-22, Secretary, Kerala Chapter of ISAR, past IAEC Committee Chairperson from 2013 to 15, past Secretary General, All Kerala Federation of Obs and Gynecologists, 2012 to 2018, member FIGO Reproductive Medicine Core Committee, 2013-14, Suffolk Executive Committee member and Journal Editorial Board member. Sir has many awards to his credit: Foxy Korean Award, Kamini Rao Yuva Oration Award, and many more. I welcome Sir.
Thank you.
We have Dr. Andali Agarwal ma'am, who is a senior member of Foxy from Allahabad. She is a past president of Allahabad OBGYN Society with special interests in high-risk pregnancy and infertility. I request ma'am to introduce our guest speaker, Professor Jaydeep Malhotra ma'am. Dr. Andali Agarwal ma'am.
Dr. Andali, are you there?
Yeah, I'm here.
Yeah, sure. Can you have Dr. Nina Malhotra CV, please?
Good evening, honorable guests of honor, other dignitaries, faculties, and friends. At the outset, I'd like to congratulate you, Dr. Asha Rao, and your team, Dr. Jayashree Sridhar, Dr. Vartika, for organizing this webinar and making me a part of it. This is a nice series of seminars you all are doing, the Foxy Symposium on Endometriosis. Endometriosis, we all know, is an enigma, and it is a dilemma to treat it. And the bigger dilemma is to give a lasting result, as it follows every woman right from adolescence to menopause. Endometriosis in adolescents has been very nicely covered by Dr. Arjuna Dixit. Now we come on to the reproductive age group, where the presenting features are mainly two: pain, pelvic pain, abdominal pain, and infertility. In this session, what we will do is we'll take up infertility, because this is a very, it is a cause of great concern to the couple involved. Okay, and for this we have with us is Dr. Jaydeep Malhotra, who is a well-known person, a well-known infertility specialist from Delhi, AIMS Delhi. She is an MD, DNB, FRCOG London. She is professor and head of unit at the ART Center, Department of Obs and Gynae, All India Institute of Medical Sciences, Delhi. Secretary General, Indian Fertility Society for 2020 to 22. She has had training in ART at Assisted Reproduction Unit, Aberdeen, Scotland, Yale Fertility Center, Yale Medical School, USA. She has a fellowship in Commonwealth and is a Commonwealth Fellow and Voice Card Fellow, DST. Her awards include Sir Malcolm Black Fellowship 2015, RCOG London, Overseas Fund 2010-2018, RCOG London, Imaging Science Award, Foxy 2006, CS Dawn Award, Foxy 2009, 10 and 11, Corlon Research Award, Foxy 2010. Her clinical interest is in reproductive surgery for endometriosis, and research interests endometriosis, genital tuberculosis, and implantation failure. Over to Dr. Nina. The stage is yours now.
Thank you, Dr. Am I audible?
Yeah, you are.
Yeah. Thank you, Dr. Agarwal, for this kind introduction. At the outset, let me thank Dr. Asha Rao for having me here for this session on endometriosis. I think really indebted for two reasons. That endometriosis is close to my heart. And secondly, you gave me the opportunity to interact with a very close friend, Arjuna. If Arjuna is around, I bring to record, me and Arjuna have very good memories. Both of us worked together in the same unit at Lady Harding. While she did a post-graduation, I was a registrar. And then when I was in London, she was my go-to person when I took the membership exam. So I would be failing to acknowledge that when I took my membership exam, she really mentored me to get me through the exam. Thank you so much, Ashna, to sort of be here. I think it's like meeting over Zoom. Thank you, Dr. Asha. So moving forward for optimizing ART, and as Archana has already set the ball rolling, with the girls, young girls who suffer this enigmatic disease, I think when they move to womanhood and move into the reproductive years, the disease takes a toll when it comes to infertility. I really don't want to tell you these figures, they're all there in textbooks and journals, but what's very important is it complicates the story because a lot of them suffer pain. So really we don't know how to treat because both of these forms of symptoms are exactly opposite when we talk in terms of relieving them. So again, we know that the causes are very many why women with endometriosis are infertile, and I think it's all to not just say the distorted anatomy. They suffer, problems with the immune response, also the implantation, the oocyte quality, and also the embryos that are coming out of IVF. So when we talk about ART, I mean infertility and endometriosis. If you look at ART, I just mean to say that if you look at the ASHRAE guidelines, which are as recent or as late as 2013, the recommendation says that ART for infertility associated endometriosis is to be given to women who have an advanced disease and of course who have other associated factors. So we talk about ART and endometriosis. It will definitely be the most effective treatment option when we look at advanced disease, i.e. stage 3 or 4, or when we have tried simpler forms as in ovulation induction and IUI, particularly when they kind of do not respond and have a pregnancy in up to 4 to 5 cycles. That's when with mild or moderate disease or minimal disease, that's when we are going to think of doing ART. And also if there are any associated factors, including a male factor, and more so now when we understand that reserves in these women are obviously attenuated. So what are the issues when you talk about ART in these women? Of course, the disease outcome depends a lot on what stage they are, whether they have an associated endometrioma, presence of a deep infiltrating endometriosis, and of course adenomyosis, which Dr. Rao is having a fantastic panel. So when we look around these kind of factors which are to be taken into consideration and deciding their protocols, deciding the management plans, we really need to have a clear-cut pre-IVF workup, and of course a very judicious decisions whether we are going to do when it comes to presence of an endometrioma or a deep infiltrating endometriosis. Of course, issues are around what protocols we give, what are the challenges when we pick up the eggs, and certainly what is the outcome that we are looking at. Of course, the miscarriage rates and the carry home baby rates. Of course, we know that, but whatever the pathology, physiology of the disease is, it definitely affects the ovarian reserves. Even if the reserves are good, we know the oocyte quality that we get at the end of the cycle will not be good. And of course, the disease certainly affects the endometrial receptivity. The disease per se, the process, and also we know that what will lead to is not just the quantity which is diminished, but also the quality. And of course, a lot of immune factors, including the HOXA10 genes, a lot of inflammatory markers, which get altered to even affect the endometrial receptivity. Now, we know that there is a lot of challenges when we have an associated endometrioma, particularly when it's bilateral, and that's what we sort of have a real dilemma, because not only are the ovarian reserves challenged, there are many other factors which are brought about by the inflammatory response in the presence of an endometrioma, and particularly it's not the embryo or the oocyte quality. There is also a fear, what if I enter the endometrioma while I'm doing a pickup? So all these issues are always to be taken into mind. And then when we think of doing a surgery with the ways to touch or not to touch the endometrium, I think we have to have a very, we really walk a tightrope because there has to be a trade-off, and there is a trade-off when we do a surgical removal, because when we do a surgery on an endometrioma prior to an ART cycle, we know we run the risk not just of bleeding, infection, of a diminished ovarian reserve, but of course, we may even be delaying her ART cycle, which perhaps would definitely have to wait for a couple of weeks. So again, if we take the IVF cycle with an endometrioma, right from the accidental puncture of the endometrioma to development of an infection. And of course, what will be the challenges when we are to put in a needle there? So all said and done, what we really know that there is an effect of endometrioma on controlled ovarian stimulation as well, because these ovaries within endometrioma do not do as well as an endometriotic disease, which is without an endometrioma. So certainly to look at this, if you look at what is the systematic review and meta-analysis, which comes the one which is really the largest from the human reproduction update of 33 studies, clearly says that they looked at the primary outcome as live birth rates. They did say that the outcomes were comparable, but certainly women with endometrioma had higher cancellation rates, and also those who had been surgically managed had a poorer IVF outcome, including ICSI outcome, vis-a-vis those without a surgery. So without doubt, presence of an endometrioma reduces the ovarian reserves, and much of it is not just attributed to the surgery, but actually to the endometrioma per se, which not only stretches the ovary and reduces or the quality and quantity, but also brings about a lot of toxic changes within these Graafian follicles. So really, if we have to do a surgery, which we may be forced to do, I think the choices are between either a surgical excision or a fulguration. And I'm sure there is again a debate which still needs to be resolved, whether we do a cystectomy or simply do a drainage and ablation. But obviously, while cystectomy is definitely a way to be very careful with a good surgical hands, reduces the risk of recurrence, it definitely results in more follicular loss and impaired or lowered reserves as compared to just an ablation. So again, I think this is something which really needs a lot of randomized trials, but I think in a subject like this, going in for RCT would really be very, very difficult and an arduous process. So needless to say, whenever you're trying to do a surgery in women who are planned for an ART or even otherwise for any ovulation induction, to know their ovarian reserve pre and post surgery are absolutely mandatory. And I think nothing better than an AMH comes handy for these cases. Now let's look at, when we know that there are all these kind of risks associated with surgery, is surgery really indicated before an ART? And what are the areas or what are the situations where we should put or force our patients to surgery? And I think this is an old paper, though 2009 by Juan Velasco. It clearly says it's only reasonable to touch these patients if there is a big cyst or a big endometrioma, which may be likely to interfere your needle access, or perhaps you contemplate that this will be impairing or impinging on the growth of the follicles, but otherwise should not. And if you look at the various guidelines, be it the ASRM, ASHA from the Chinese group, they clearly say that if there is an asymptomatic endometrioma or there is an endometrioma which is not huge enough, I think it's wiser not to touch, because if one has to, I think even a drainage could be considered impeding the oocyte, only if it's there to be impeding the oocyte retrieval, should there be an indication. So neither aspiration nor cystectomy actually improves the IVF outcome. And by IVF outcome, I mean live birth rates. So only if there is a hydrosalpinx or when the accessibility to the follicles is getting compromised, should you really put in a scope prior to an ART cycle. And again, if you look at the meta-analysis, which is a systematic review from 11 studies, which is recent 2018, clearly says that you have to really weigh the surgical risks versus the benefits in terms of ovarian reserve when you put in a scope there. A big challenge again comes when there is a lady, she has been operated, she's planned for ART, but she defers it for whatever reasons, and then she comes back with an endometrioma. Should you really go ahead? Remember, whenever you're going to really rescope her or resurgery her, there will be a further decline, because it said that there is a decline of up to 1.5 nanograms per ml, which will be quite big for somebody who already has an endometrioma. So again, I think one has to be judicious, and certainly if there are surgeries to be done, very meticulously done, definitely by somebody who has the skills and not a novice. So clearly one has to avoid surgeries when it's a recurrent disease. Now, what about deep infiltrating endometriosis, particularly when it's for the rectovaginal septum? I think the jury is still not very out, because there are kind of debatable kind of answers. If you look at the French registries who really swear, they say if you kind of remove and do away with the deep infiltrating endometriosis prior to AT cycles, then that really improves the outcome. As contrast to some papers where they say that there is definitely a benefit, to others who really say that it does not make a difference. I think something interesting in this article, which was there, and is again a large study, which comes again from Turkey, which said that when they looked at women who had prior IVF failures, i.e. implantation failures, with severe endometriosis, surgical removal definitely improved. So I think one again has to look into the situation and what are the surgical skills available when it comes to removing rectovaginal septum and deep infiltrating endometriosis prior to taking them up for an ART cycle. Well, again, once you have taken a decision, taken a call, well, I'm not going to do a surgery, do you think there's a benefit of putting them on medical therapy, i.e. putting them on analogs? I think this is pretty old. When Hassan Salam's Cochrane review said that you put them for up to 6 months, it improves. And I put a big question mark that it improves oocyte and embryo quality, because putting them for up to 3 to 6 months would really be delaying the ART cycles. And therefore, I think this 2019 Cochrane from the group clearly looks at and probably contradicts the earlier Cochrane. And this was generally looking at women who were planning an IVF cycle and clearly says we're still very uncertain about the benefits because it does not improve the quality or the number of oocytes if the analogs, GnRH agonists, are given for as long as even up to 3 months. Now, talking about the stimulation protocols, because there are challenges again, because we really know that there are women who are compromised in their results. Even women who have minimal or mild endometriosis may not do as well as women who are out with endometriosis. We know that even if they are responding, the cycle cancellation are higher for reasons of empty follicle. And also, while you're stimulating, many a times an endometrioma was just 3 centimeters in size. Under the influence of the hormones, grows bigger. So these are all the problems. So I know that we have really grown up and we realize that the long protocols, the ultra long protocols are an advantage. And certainly we know the advantages are very many because they just don't work to kind of decrease the vascularity, but they improve the milieu and also inhibit a lot of toxicity that would happen to the eggs and oocytes. But then you have to really weigh the disadvantages, because if you go longer in downregulating, the longer you would need in time and also in terms of dosing when you need to stimulate these ovaries, because these ovaries are very hard to be woken up once they really are dormant for long. And also we know that the ultra long may result in a reduced number of oocytes that may be retrieved at the end of the cycle. So really, again, a lot of debate going there. A wonderful, RCT, which looks a meta-analysis which looks at 21 RCTs, and it says that you should restrict for ultra long only when you're looking at advanced or severe diseases, and perhaps stick to maybe long protocols for stage 1 and 2 disease. Now, again, choosing between the agonist and antagonist, because we realize that even antagonists do as good. So I looked up the literature, which was on head-on-head antagonist versus agonist, and not very many papers, but I think certainly the agonist, the tilt is more towards the agonist. The reasons are that even though antagonists are friendly in terms of time and money, the number of oocytes that you get and the number of embryos you get are definitely better with agonists, and therefore the cumulative live birth after a frozen embryo transfer will certainly be better. So these are some of the papers. And if we look at comparisons between women who had an endometrioma resection and then went into an agonist or an antagonist, so not a very big study, smaller one, it clearly points out that they had similar outcomes, but the agonist protocols again gave you better number of embryos with an option of higher cryopreservation. Now, just comparing, the live birth in women who have diminished ovarian reserve, because, we will be very happy to take somebody for an antagonist, certainly if she has a diminished ovarian reserve, because in this group of women who have compromised ovarian reserve, i.e. low AMHs, and especially when they have a history of a cystectomy or surgery done, antagonists would definitely reduce the time and cost of the cycle. But again, the long would certainly be helpful because you're still getting more number of embryos. So having had the stimulation, now is the challenge of the pickup. We know that there'll be difficult ovaries. Many times they're not just stuck behind the uterus, they just sit on the uterus. And I think there are times when some of you will recall we have to resort to a trans-abdominal route to their pickup. And also when you track your needle through the endometriomas, because you run a risk, the patient of an ovarian abscess, and we do see that could be really a horrendous kind of an experience. And certainly the follicular fluid that comes, if it's contaminated, we all know that the embryologists are very wary of this. So when we hand over these oocytes, what are the issues that our embryologist would definitely face? Because he knows that not only they're laced with the endometriotic chocolate fluid, but the competence of these oocytes is not as brilliant as would be for any woman who is not having endometriosis. And for this very reason, I think this is the only JAG paper which was a randomized trial, which said that if you're doing a conventional IVF vis-a-vis ICSI yielded better fertilization rates. And then there are some papers, though they're not randomized, there's retrospective data from China, which doesn't find ICSI to be very, very useful. So there is, again, the choice how your embryologist feels on doing an ICSI all on these oocytes versus doing a conventional, insemination. And the reasons that are best understood is that not only is the number compromised, we know that the quality of these oocytes is poor because of the spindles and the mitochondrial contents, and also for the zonas, which are definitely hardened and thickened. And of course, there is a lot of papers which suggest that these oocytes even fail to undergo in vitro maturation because of the internal milieu of these oocytes, which is definitely attenuated and altered. Now, when we know that you've gone in to have these oocytes picked, you've done an ICSI or an IVF and got embryos, the real challenge and real question then arises, should we put them back in the fresh cycle frozen? Again, no robust evidence on the ASHRAE, really not clear-cut guidelines, but certainly they say that even in mild diseases, leave alone the advanced endometriosis, if you do a frozen transfer, you stand a higher pregnancy rate, obviously because the endometrial receptivity is depleted in these group of women. And also we know that the miscarriage rates will be lower in women when you put them back in a frozen cycle. I just won't really talk in detail about adenomyosis because we have a full, panel on this, but I think this is again a Waterloo and a difficult area when we get a woman with endometriosis for an IVF and a big uterus. And we know that there are all very reasons why these adenomyotic uteruses are stubborn and hard nuts when we want to put back even the best embryos, even if they come from a donor cycle. And of course, there is a good lot of papers with systematic reviews clearly saying that the impact of adenomyosis is far more humongous in terms of live birth rates for reasons that are best understood. So should you really do a surgery or not? I'm sure this will be deliberated, but yes, if it's a local or a focal adenomyoma, perhaps you could do an excision, but when it comes to diffuse, I think that's where the challenges are. Even if you're a skilled surgeon, you do techniques, but certainly you give them long protocol in terms of suppression, which is longer, health, and definitely if you do a combination of surgery with long down regulation with frozen cycles, live birth rates are certainly better. So I would just kind of look up to what really are the questions that your patient or the couple asks us. And I think they are, doctor, what will be my outcome if with this kind of endometriosis or with this kind of an endometrioma or this kind of a deep infiltrating endometriosis, are my chances of having a baby? And I think that's what we need to answer and think. And I think we have to be very wise to not paint a rosy picture because a lot would depend on what stage of the disease they are, whether they have an associated endometrioma, which certainly worsens the prognosis, and also if they've had an ovarian reserve, which is compromised, and definitely if it's a recurrent disease. So we look at options which in our IVF process would optimize or improve the ART outcome, certainly would be a GnRH analogs, which could be given. I really don't say 3 months, I put a question mark, but something which would be of benefit would be giving them LON protocols, maybe doing ICSI. And I think with improved vitrification, embryo vitrification, and a deferred embryo transfer that could be. For, of course, adenomyosis, I think cytoreductive surgery and a combination with GnRH analogs would be definitely an option before you go in for an FET cycle. So really, to put it in words, is the outcome really poor or the prognosis really sad? Should this be the answer? I think if you look at the SOT database, which is a little old that I could come, they really point out to similar pregnancy rate and live birth rates. But if you look at the ASHRAE and the other Danish registries, they clearly point out that this group certainly has lower ART outcome for reasons best known. And if you know that is the outcome really bad, I think with the exception of patients, most patients who have mild or minimal diseases, the success would be good. Yes, endometrioma spells are not a very good prognosis. So I think we have to be wise and cautious when we do these patients. So I would just kind of wind up here to say that it's very important when we take a woman for IVF, a counseling and a thorough counseling is very, very important. Look at endometriomas with due respect, rather than just putting scopes in left, right, doing surgeries. Definitely preferring an agonist protocol. And of course, what really matters is the female age, besides all the factors that are going to be really answering the prognosis for this patient. So I think I would end here and would be happy to take questions at the end of.
Thank you so much, Dr. Nina. Thank you so much, Dr. Nina Malhotra. It was a fantastic lecture. You have covered all the points in a very, very clear way. Such a complicated topic. You made it look simple and answered everything beautifully. I would like Dr. Fessy Louis to make a few remarks. Everybody can put their questions in the chat box, please.
I think there is nothing more to cover because Nina has covered everything, right? From the ART perspective, right? From the stimulation part with the latest with the data and comparing the different protocols and including everything she has covered. But and one thing what I think Nina had put in her slide is, and that's coming up, is that initially people were, especially when the ovarian reserve is less, they were very worried about the long protocol. So now there is a new concept, but I don't know the studies I have seen before, but only one study. You go for a antagonist protocol, retrieve the oocytes, and transfer in a deferred cycle, as you told, Nina, but in a prolonged suppressed cycle of suppressed with a GnRH agonist. And that is the one which is coming up. I have not seen much larger studies or any articles about that. You can add to that, Nina.
Yeah, Fessy, you're right. There's not much, but yeah, lately, there are a couple of studies which have come up, but then they are more on the women who've had repeated or recurrent, surgeries, because there they feel that the cancellation rates would be lesser, as we all experience in poor, prognosis in the pozoidin group, as we kind of tend to stick to the poor prognosis more an antagonist. But I think that data is small. So I think we have to really pull in data where we can say, yes, time will tell us that antagonist, but certainly it'll be more patient friendly in terms of a pocket, because the antagonist in the long term will be lesser days of stimulation.
And another thing is that there is no clear cut off above this much size of endometrium or above less than which amount of AMH you must directly go for ART. So that is the thing.
I think you're again said, I think as a 2009 paper, which was kind of, and again, many, review articles said 5 centimeters, but I don't think that 5 centimeters really work, because there'll be somebody who will actually be troubled by even a 3 centimeter, which is tending to grow big, whereas sometimes you are very confident there's something like 7, 8 sitting away from the ovary, and there's an ovary which is present eccentrically. So I think it's again on your judgment and how you do a baseline scan and how do you go. I would say such patients should certainly go to a senior person. Like, you put in a scope, send her to a senior, kind of as laparoscopic surgeon. So, there are times when I have not fiddled with the large endometrioma because I knew it was not coming in my track at all. So why do I compromise the reserve? Because it's very easy that you drain and come, but if you fiddle on an endometrioma, needless to say, you will be quartering her, even if you have a laser or whatever, kind of energy source. So I think if you can sort of, refrain from or being tempted, but then I think you have to be very judicious. If it's something which is going to come in your way, or you're going to make your, even if it releases your ovaries, so that matter, which are sitting high up, why not put in a scope and get the ovaries down? Because at the end of the day, you'll be able to pick up more oocytes. So I would say that judicious thinking again.
Yes.
Yeah, Dr. Nina, you have one question in the chat box. LNG IUD instead of depot before thought transfer. Can you try that?
Yes, I have done it to a lot of my patients, particularly those who have adenomyosis. And, it really works good because, what she gets a benefit, she gets an added benefit of pain relief also, because while she's waiting, the pain relief she gets with an LNG IUS is much better than just giving her a GnRH. I'm sure that's what a lot of us do. And the worry is people worry that what will happen when we kind of remove the LNG, because that will suppress the endometrium. Anyway, when you're going to take them, you will anyway be giving her, as a replacement in preparing her lining. So, and again, there are a lot of papers where, they have tried the LNG IUS vis-a-vis the depot preparation. So you can certainly do that.
Thank you, Nina. There is one question for Dr. Archana. In fact, that's from me. Dr. Archana, what is your preference for these young girls? Is it OCP or is it progestins?
So my personal preference is OC pills, unless there are any contraindications to put them on the combined pill. Progestins cause a lot of side effects, a lot of progestogenic side effects for these young women, which they find very difficult to cope with. Things like moodiness, depressive symptoms. Many of them break out in acne. and they don't like all the irregular, erratic bleeding they may get on that. So I think they cope much better with the combined pill. I think you'd also asked in the chat box about the levonorgestrel intrauterine system, and I think it definitely does have a role. However, with the Mirena, you never get the systemic levels of progestin to suppress endometriosis. It's an excellent treatment option for adenomyosis to manage the pain and heavy menstrual bleeding, but for endometriosis, it doesn't seem to work that well. Of course, many of these young women are not sexually active, so it's not an appropriate choice for them anyway. But definitely as an adjunct to surgery, so if you're doing a laparoscopy and treating or ablating their endometriosis at that time, that's the time to put in your Mirena for preventing kind of progression and reducing recurrence.
There's a couple of recent papers by Verslini and also by Chaperon. They said that deep infiltrative endometriosis may progress when you give them OCP. So Diagnost is preferred. So is it propagation by the company, or because many of us have used OCP for a long time? Dr. Nina, also, after Archana, maybe. Yeah,
I think it's a very pertinent question, because I have read those papers where they are preferring. I really can't say whether it's company sponsored, paperwork, because they tend to tilt and there is a bias. But yes, I think it's again to do with the disease pathology, because certainly the disease is far more advanced and deep-seated. So perhaps that could be the answer. And again, I think, Arjuna, would be that we really don't have much experience on the use of Diagnost as when it goes to deep infiltrating on. So perhaps a few more papers could add. I just see a question which says, what is an experience of Diagnost pre-IVF? I kind of deleted 1 or 2 slides which I had, though we just completed a randomized trial, which was a part of a DM thesis, in which we kind of randomized one group to have a GnRH analog versus Diagnost to look in what is the difference. Well, certainly we gave these patients, up to 2 shots or 3 shots of a GnRH vis-a-vis up to 12 weeks of Diagnost. We really didn't find any difference in the oocyte quality. Whereas there are some papers which say that Diagnost doesn't seem to work very well pre-IVF as compared to the GnRH. So again, this is a newer kind of a sort of area where we again need more papers to say what will be the difference in the if you give pre-IVF Diagnost or GnRH. So that's what I could see on the chat box.
So I definitely, first of all, Dr. Nina, let me also share my delight in sharing, even if it's on Zoom, sharing stage with you, and thank you very much for your lovely, kind words about me mentoring you. Gosh, how would I mentor you? No. I still remember our Lady Harding days, and you've taught me so much. So I'm absolutely delighted to hear you and be here with you. On the subject of Diagnost, again, I'll probably say that I might not be the right person to answer this, because again, as you all probably know, working in the UK, we do not have the luxury of trying out kind of things which come out in papers very easily, because we are much more regulated by the National Institute of Clinical Excellence, and by the time things get into the mainstream medicine in the UK, they have to have had plenty of robust trials before we will be using them clinically. So I don't have much experience of using Diagnost. However, as Dr. Nina has said, I think it might be more to do with, when you use it, in which stage of the disease you use the combined pill or Diagnost, which might make a difference. But I think, we all need to watch the space. I'm sure we'll have loads more trials coming out and more evidence to base our clinical practice on.
Yeah. Any comments on use of aromatase? One is for pain and second is for pre-ART from both the speakers.
Again, I have not personally used. There are a lot of papers which swear by not just letrozole or other aromatase, and also a combination of letrozole with bromocriptine. This is what has been there in small, studies from Egypt and Turkey. I really won't say that there are any robust evidence to say it is for benefit in terms of pain, but certainly, we do tend to, see patients come up with this kind of combination coming from clinicians, but I don't have experience. Yes, in terms of some antagonists, which is again, some work happening in the US, and approvals are awaited from the US FDA, is the use of Elagolix, which is an oral kind of antagonist, which is coming in a big way and maybe coming soon to India on pain relief and endometriosis. But again, there's just limited work there. And the other thing you talked about was on the use of letrozole in infertility. Well, I have used it in a kind of way to say in mild minimal disease, but really one can't put it as a randomized trial, really not much. I think I would tilt more towards gonadotrophins when it comes to using endometriosis than, using
I did use it. I did use it, Nina, for a couple of patients who did not respond that well to GnRH analog with adenomyosis. So endometriosis with adenomyosis. The volume regression was not so good with GnRH initially. So later I added aromatase inhibitors, and a few patients have conceived. So last year I started a study. Let me see by the end of the year how it goes for adenomyosis with endometriosis for volume reduction.
I think I would agree with whatever Dr. Nina has said. Certainly from the pain perspective, I don't do fertility treatment, so I can't comment on that. But for pain management, I certainly think I think it's too early to start using these medications in the mainstream.
Is letrozole allowed in the UK to use?
No,
you
add up, madam. Then I talk. Not for endometriosis management. It is used for treatment in subfertility, yes. But not.
Can I ask Dr. Archana one question? Because even though we see that endometrium in adolescents, it affects their future ovarian potential, but it has been seen that some people, when they have slight pain or slight discomfort, they go for laparoscopy surgery. But something message you can give to the routine practicing gynecologists in perspective of their future fertility potential?
Yeah, so I thank you very much. That's a very, very pertinent question, particularly for the adolescent age group. And I would definitely advise against rushing in for surgery in these young adolescent women, because you may actually be causing more damage to their future fertility than any benefit. So I certainly don't think that laparoscopy should be the first line treatment, neither for diagnosis nor for treatment in adolescent endometriosis. It needs to be reserved for second line to those who have failed to respond to medical management, and use it quite judiciously. And also, if it is to be done, it really needs to be done by people who are experienced in laparoscopic surgery and can treat it at the same time judiciously, rather than just everybody trying to put a scope in to make a diagnosis.
Yeah. Any comments from Dr. Barua?
Yeah, exactly. I just wanted to know what is the evidence they do really recommend from the UK on using IUS for adolescent endometriosis? Because we personally use it not at random, but we really get good evidence from this. But what is their recommendation in the UK? Because we always look at the RCOG guidelines and RCOG recommendation for IUS in adolescent endometriosis.
So certainly IUS is the first line recommended treatment for adenomyosis, for treatment of adenomyosis. And we use it as the first line for that. It is recommended and is very, very effective, as I'm sure all of you agree with. For endometriosis, for adult endometriosis, again, it is one of the recommended treatment options. However, for adolescent endometriosis, as we're discussing about that, it is not the first line. And the combined pill or progestins or progesterone only pill are more the first line treatments as opposed to the levonorgestrel IUS.
Yes, Manisha, I think it's time to wind up, Manisha. It's already 6:30 for the panel. Those are excellent. Both of them spoke so well.
Indeed, ma'am. I think we are like on a verge of knowledge at that particular time. I think we are supposed to wrap it up right now. I think we have more questions coming up soon. So we are moving to our next power pack sessions, that is
always under the supervision of a diabetic
on the adenomyosis, changing the paradigms and the management. For that, we welcome our moderator, who would be our dynamic Dr. Asha Rao Mam, and the panel expert being none other than our dearest Dr. Ritu Khanna ma'am.
Thank you.
So Asha ma'am has already been introduced, and I think nobody needs further introduction from the dynamic personality such as her. as a moderator, ma'am, and we are going to share now Dr. Ritu Khanna ma'am. Hello, ma'am.
Hello.
Hi, ma'am. So, ma'am is a gold medalist in Gynec department and is a director in Khanna Medical Center with the fertility clinic, and is a well-known, renowned personality known for her IVF department. She has the organizational position of currently of a chairman for elect Foxy in the Food, Drug and Medical Surgical Equipment Committee currently, with the Secretary Society of the Fetal Medicine UP chapter, Vice Chairperson, Women Doctor Wing IMA Benares branch, with the previous Vice President Vox Secretary and Joint Treasurer of IFS. Along with, she is currently working on exclusively single embryo transfer. Has been awarded with Best Chapter Award as a Secretary IFS UP Chapter in Fertivision 2015, and IFS Best Executive Award of 2016, and has published several papers and publications over the national and international levels with the field of interest in laparoscopy and cystoscopy fertility enhancing surgeries. We welcome you, ma'am.
Thank you so much.
We now move on and introduce the panelists who will be following. Can we have the next slides? Apart from, yeah. So we welcome Dr. Manisha Gupta, ma'am. Hello, ma'am. Ma'am is from the MLM Medical College, Allahabad. It's a senior consultant gynecologist, Allahabad. With the Vice President, Allahabad OBG Society currently, and Vice President, Allahabad OBG Society State Medical Council member of IMA, Chairperson Mission Pink, Allahabad, and special interest in infertility and cancer screening. We welcome you, ma'am. Dr. Sangeeta Rai, ma'am, is none other than an consultant from my own department. She's presently a professor in Department of OBG in IMS BHU, as a senior registrar in gynec oncology, has done in 1 year in Dharamshila Cancer Hospital, Delhi. Has been a secretary of VOGS in 2018-19. Member of Mamta Adolescent Health Clinic, member of AGOI.
Sorry to interrupt, Manisha. We have very less time, so please, can you just...
Okay, ma'am. She's the current coordinator of Lakshya Committee in BHU. With the next slide, please. We welcome Dr. Chitra Pandey, ma'am. She's a current director, consultant in OBG Society of Harsh Hospital, Allahabad, and has done a fellowship in ISCOG and vice president of ISOPAB Prayagraj. We welcome you, ma'am. Dr. Divya Agrawal, ma'am, is none other than the president of Varanasi OBG Society currently, and has done a fellowship in reproductive medicine in Germany with the IVF specialist and director in Ayushman Multispecialty Hospital and Morpheus Akriti in Varanasi. We welcome Dr. Pragati Agrawal, ma'am. Ma'am is presently a secretary of Bareilly OBG Society and past treasurer of Bareilly OBG Society with the past treasurer of midterm UPCOG, and has been awarded with many paper and presentation over time. Next slide, ma'am. We welcome Dr. Parul Garg, ma'am. Ma'am has done her MD from LLRM Medical College, Meerut, and is currently professor and HOD of the Department of OBG, KD Medical College, Mathura. We welcome you, ma'am. And Dr. Ishita, ma'am. Ma'am has done an MD from IPGMR, Kolkata, and is director of Upha Nursing Home, Varanasi, with the area of interest in colposcopy, uterus conserving surgery with high-risk pregnancy. We welcome you, ma'am. I think, ma'am, we can move on with the questions now. Hello.
Yeah, okay. Thank you so much, Manisha. And let's go ahead straight away with the panel. Let me just start share my screen. Yeah. So greetings to all of you from the beautiful city of Adiyogi. Now we have come really under the red alert for Corona. So I think in this scenario, the webinars are really giving us a fresh breath of thinking. And I thank Dr. Alpesh Gandhi for having given us his support always throughout the year. And adenomyosis, by definition, is benign invasion of endometrium into myometrium, producing a diffusely enlarged uterus. And initially thought to be found only in Paris women, and diagnosed historically by histology after hysterectomy. So today it is seen more and more in younger women and nullipara. Is it because of better imaging techniques, or is it because of women postponing their fertility from 20s to late 30s? Perhaps both. The prevalence in general population is about 5 to 10%, and 30% can be asymptomatic, and 20% of women below 40 years at ART could be having endometriosis. And this is a tremendous change in trend, which made me talk throughout the year about adenomyosis, because very many of us are well versed with endometriosis, but when it comes to adenomyosis, people say, oh, I do not know much. Or there's always a tendency to think, shall we do a surgery? Just like endometriosis, this is a disease where we are trying to tell everybody that operate less often. It is a chronic disease, lifelong disease, so let us manage it medically rather than surgically. 21% of women with endometriosis concomitantly had adenomyosis, and 54% of young women with infertility and dysmenorrhea and menorrhagia could be having adenomyosis. And 28% of subfertile population has adenomyosis alone. So thank you, Dr. Ritu, for accepting to be my panel expert. And I welcome all my panelists who have already been introduced. So the first question goes to Manisha. Manisha, how do you diagnose adenomyosis?
So basically, with the advancement of the ultrasound and various sonographic measurements, there are non-invasive and invasive methods. Now, non-invasive now comes back to TVS. The 2D, that is another than is there are the 3D ultrasound. Apart from the fact that we can also use the color Doppler for the fact to recognize whether the lesion that is there, that could be global or localized, whether it's a fibroid or an adenomyosis. So Doppler really helps.
First of all, I would say you must go by symptoms and signs, both,
Yes,
a history of severe menorrhagia and intense dysmenorrhea, which is seen in 50% of patients, gives you the clue that it could be adenomyosis.
Absolutely, ma'am.
And infertility also is being considered as one of the symptoms of adenomyosis, which we discussed that is seen in about 30% of patients.
Yes, ma'am.
Yeah.
So now
my request to the digital people who are handling, if you can mute everybody else other than panelists, do you think we'll have less noise?
Sure.
Or one of the panelists may have two.
Yes,
yeah. Okay, much better. Yeah, sure. No, okay. Is anybody having two devices
at the same time? Can you please mute yourself? Yes, ma'am.
Okay. So yes. You continue, Manisha, quickly. Yeah.
Yes, ma'am. So basically, it is about the knowledge. Apart from the having the clinical awareness, we also have to go for the about the signs and symptoms, and now the investigations. Investigations now includes non-invasive. The non-invasive goes by the transvaginal ultrasound, is much specific and has been found to be highly sensitive and specific. Apart from the fact, now the recent diagnoses have also come up with the 3D ultrasound, which is now they are saying that it is as sensitive as the MRI pelvis, ma'am. And apart from the fact, they have also recent advancement of knowledge of an elastography. And now elastography has also been showing that because of the architectural disability in the structure of the uterus, they have shown that the uterine musculature becomes softened under the effect of the adenomyosis, and has shown when the elastography is also like the color Doppler has been shown, there will be a bluish greenish color, which suggests there is a softer tissue as compared to the bluish coloration in the fibroid. When we come to the Doppler, there is a thing when we show that there is a very peripheral vascularity that is also known as a translesional vascularity that is present in the adenomyotic feature, and which gives a signs and symptoms suggestive that ultrasound will give a diagnosis of that particular thing at the sensitivity and specificity of almost 90%.
Yeah, thank you, Manisha. You said it right, that ultrasound has a very good accuracy in diagnosing adenomyosis, almost the extent of 80%.
Yes.
You have 7 signs which are seen here: heterogeneous myometrium, globular asymmetric uterus. If you can see 3 out of 7, you can diagnose adenomyosis with confidence.
Absolutely.
And it's a disease of the junctional zone, which you can see here, the endometrium, myometrium, and the subendometrial myometrium. This thin halo is called the junctional zone, which is barely 4 to 5 millimeter in normal women. And if it is more than 10 millimeter, you can suspect adenomyosis. And if it's more than 12 millimeter, you can definitely diagnose adenomyosis.
Yes.
And Chitra, what is the role of 3D or MRI?
I'm actually 3D. We can see the uterus in coronal section also in 3D. So 3D gives better delineation of junctional zone, and we can measure the thickness of the junctional zone more accurately. So 3D can provide us a diagnosis of the adenomyosis at the earlier stage, and we can delineate junction zone, and even the smallest aberration or smallest invasion of the endometrium we can detect at the earliest. And if there is thickness more than 8 millimeter, or if there is difference in the thickness more than or equal to 4 millimeter, then we can suspect that patient is having adenomyosis.
Yeah, this is the way you diagnose by 2D, when it's too late. Yes. Whereas if you diagnose it like this by 3D, so today 3D should be a part and parcel of your machine. You should not be referring the patient out for another ultrasound with another person. So it's very wise that all of you have a 3D attachment. Here you can see the junctional zone here near the endometrium, myometrium. This is the early infiltration.
Quick area around the endometrium we can see.
This is the focal adenomyosis. So with 3D, you can diagnose it beautifully, just like MRI. MRI, though it's a gold standard today, because of the expense, I would say it's ultrasound with 2D and 3D. You can diagnose it with 85% accuracy. So all my dear fellows, kindly learn to use 3D and 2D ultrasound accurately, and you can diagnose adenomyosis beautifully. And this is the classification. Simple junctional zone hyperplasia, more than 8 millimeter, but less than 12 millimeter, partial or diffuse adenomyosis. And the fourth one is adenomyoma, which is a cystic area in the posterior posterior myometrium is called the adenomyoma. This is a very simple classification. Here you can see the focal and diffuse adenomyosis. So any role for tumor markers, Dr. Ishita? Are you there, Dr. Ishita?
Yes, ma'am. Ma'am, please unmute yourself now.
Okay. The role of tumor markers, ma'am, I think if actually there is the adenomyosis is actually, as you've rightly said, the disease of from history and 2D ultrasound and a 3D. 90% to 95% of cases can be diagnosed easily.
Yeah, so we would say that tumor marker has very little role, just like endometriosis. Sometimes for a follow-up, you can use CA125.
Yes, and at times it is marginally increased, but otherwise not much role of tumor markers in this.
Thank you, thank you. So the question goes to Pragati and Parul now. What are the problems of adenomyosis on fertility? And what is the etiopathogenesis? So one person, one question. Pragati, first questions. What are the problems of adenomyosis on fertility?
Though at present there are no conclusive evidence that adenomyosis causes subfertility or infertility, but there are many studies which suggest that it is associated with subfertility and infertility, and even there are implantation failure during IVF, and then during pregnancy it can lead to recurrent miscarriages and even PIH. These are all complications during pregnancy. Yeah. And as we know that the pregnancies, there are various factors for the pregnancy. The sperm transport is required from vagina to uterus and then to tubes, and then this everything this transport is affected due to the action of the endometrium and myometrium. These are deranged. There are various genes and proteins which are deranged due to the adenomyosis. This causes altered uterine peristaltic activity. This is due to destruction of as junctional zone myometrium. There is gene dysregulation of endometrial proteins. These all.
Thank you so much. So adenomyosis can cause infertility, as you rightly said, and it can also cause poor placentation, miscarriage, preterm labor, IUGR. So many obstetric dysfunctions could be because of adenomyosis. So whenever there's a recurrent implantation failure and recurrent miscarriage, recurrent preterm labor, you have to practically hunt for adenomyosis. So, because what the mind does not know, the eyes will not see. So once you're suspicious, once you're aware of it, you will definitely diagnose adenomyosis, because with their own patients, what we're seeing today, maybe perhaps 15 years back, we're not seen. Since we maintain the records, we could go back and see. And we have a study of adenomyosis from 2005 going on. So it was nice reviewing our own findings. And adenomyosis causes changes not only in the adenomyosis, that is ectopic endometrium, but also in the utopic endometrium. The implantation factors favoring implantation are decreased, and the factors adverse to implantation are increased, in addition to increased peristalsis, and which are all important for causing all these dysfunctions. I think I'm moving quickly now, because otherwise we won't be finishing. And what are the thoughts? Sangeeta, what are your thoughts on managing adenomyosis? What are the methods of managing?
Ma'am, we all know that it is a benign uterine disorder which causes dysmenorrhea, all the pelvic pain symptoms, abnormal uterine bleeding, infertility, and it is very much clear that it affects all the age group and has a negative impact on the quality of life. So depending upon the woman age, the reproductive status, and the clinical symptoms, adenomyosis may also require a lifelong management plan, where we can combine medical, surgical, or both for better management of the patient.
Thank you. Parul, do you have any comments, Dr. Parul? What is your view of managing adenomyosis? I think you're on mute.
Unmute, ma'am.
Yeah.
Yeah, adenomyosis can be managed, as doctor said, by lifestyle modification. Along with lifestyle modification, the medical therapies are nowadays a wonderful option. So, an ultimate option is naturally we need to go for surgery.
And it depends upon the presenting symptoms, the age of the patient, reproductive status of the patient. So depending upon that, we can go for either medical or surgical or both, the combination. But yes, lifestyle modification is an integral part, and it should be go hand on hand.
Yeah, lifestyle is required for all diseases today.
Yes, yes.
But apart from that, it's the symptoms and age of the patient. That's what makes a difference. So depending on that, we have to decide, is it medical, surgical, or infertility treatment? And there are no clear guidelines, which is the time that the patient has to approach the doctor, which is the time that the doctor has to interfere and start on medication. And is it surgery or medication? Today, just like endometriosis, we are trying to make it medical management rather than surgical management, because lifelong disease, we cannot be going on doing surgeries repeatedly. Because sometimes with endometriosis, we see women would have had 2 laparotomies, 3 laparoscopies, 4 failed IVF, where the adenomyosis is also missed out, and then they have egg donation. So it's very, very important to manage them medically as much as possible, whether it's AUB or infertility. And Dr. Divya, this is Mrs. R, married 1 year. She's 26 years, dysmenorrhea. She has sharp shooting pain in the rectum, dyschezia during menstruation. She takes antispasmodics, and she's very keen on conceiving now. Married 1 year, 26 years. And this is her ultrasound.
Yeah. This we can see there is a focal thickening of this uterus, and the asymmetrical thickening is also there. So we can think she's a case of adenomyosis, and she's having a complaint of dyschezia also. It means, first of all, it depends if the patient is having a severe pain. First of all, we have to get her relieved with the symptoms. So for that, we can go for the medical treatment. And once, because her age is also less, she's around 26 years of the age.
And no male factor. Yeah.
And no factor. So we can go for this medical treatment along with that. And then if she doesn't conceive in that, and she can try for the spontaneous conception also.
What is the medical treatment you would advise?
Like in this case, initially we can go for the Dinogest also. But during that period, the patient cannot conceive. She can go for the Dinogest, or she can go for the OCPs also, or the progestin we can advise for 3 to 6 months for getting her symptoms relief. And then we can advise her for this conceiving part. For that, we can also give the mild stimulation. And for this, we can advise her for the letrozole or clomiphene citrate. So that we can.
Anybody wants to do a laparoscopy? She has got a small chocolate.
Yes, ma'am.
Can you see this?
Ma'am, I would like to interrupt, please. Ma'am, I would like to interrupt. Hello?
Yes, come on. Yes, go ahead.
Yes, actually, ma'am, if you see the ultrasound properly, there is evidence of rectovaginal thickening also in POD. So that means there is some evidence of maybe a rectovaginal endometriosis along with the adenomyosis in that. Just see in the POD, there is in the ultrasound, there is thickening on the back side.
I don't think
anybody else rapid fire. One answer.
Yes,
Dr. Manisha, what do you want to do?
I will go in for laparoscopy also. Maybe
Dr. Manisha,
and
fine. You have given your dysphagia. Dr. Manisha, what's your opinion? Quickly, 2 sentences. You're on mute.
Yeah. Ma'am, for as the chocolate cyst is very small, we won't touch it because it will hamper her further fertility prospects. So for a small adenomyosis, for that also we don't have to do anything. Only thing is that we can do some sort of releasing of the adhesions and with the help of resectoscope, and that has to also be very gentle, only to relieve her of that deep infiltrating.
So you want to do a gentle laparoscopy, right?
Yeah.
Dr. Ritu,
I won't
Yes,
do
madam.
anything for the chocolate.
Madam, if I look into this case, Asha ma'am.
Yes.
If I look into this case here on the left ovary, I can see 5 small follicles. That means she has a reserve. I just like to do an AMH. Don't touch with the focal adenomyosis and nothing to touch with this chocolate cyst. But I think do a semen analysis, male factor, madam, you said it's okay. And I think I go on directly with the stimulation. She has the best chance.
Good, very good. See, look at this finding. The first month that she came to us, small focal adenomyosis, very small chocolate cyst, not an indication for surgery, not an indication for suppression either, because you lose a very precious time. And she's already showing a dominant follicle. This is how the first cycle was. She did show some signs of DIE, but you said you are young, your husband is fine, go for a honeymoon, get lost for 3-4 days and try. So the couple went in and tried fertile period. She did one more scan after 2 days where it showed a 1.8 centimeter follicle. And we said if you do not conceive, next cycle you do the tubal patency test. Patient conceived in the same cycle. So no medication, no surgery. She's a 26-year-old with normal male factor, tiny chocolate cyst, tiny adenomyosis. No need to jump on her in spite of her symptoms. Sometimes you may not be having sex at the right time. So just fertile period she has conceived, and placenta was low lying, and she did very well. She had a LSS, 3 kg, and now she comes to you she came 11 months after childbirth with dysphagia and dysmenorrhea. So now what do? How do you help her? Quick.
Is Mirena ma'am available?
Yes, LNG
IUS.
Anybody wants to do laparoscopy?
No,
LNG IUS is best.
LNG IUS.
LNG IUS will take care
Ma'am,
of
second thing is
contraception.
if she is desirous of second child, then we would like to ask her to go and try again.
Good, very good. All of you. Yes, we told her try for a second baby, but she said, no, I'm not at all prepared for a second baby now. I had so much pain. Let me enjoy my child's growth. And because she had severe pain and signs of DIE also, we gave her GNR Chanelog. And after 6 weeks, we inserted the LNG IUD. She has done very well. It's 3 years now. And we told her, look, it's time you remove it and try for a second baby. She said, no, I want to wait for 5 years and then I'll try for the second baby. Good. Thank you all. So we're all thinking alike now. And now this is the next case for Manisha. 34 years, infertility 5 years, severe dysmenorrhea. Regular periods, normal male factor. She had grade 4 endometriosis had a laparoscopy 3 years back. She also had a failed IVF 6 months back elsewhere.
And she has already had a failed IVF 6 months back. And in between, I don't know whether she has taken treatment. Most probably she has not taken any treatment. So I'll again reassess the patient, and the AMH 2.3 is just borderline, because in endometriosis, the AMH is sometimes falls positively high. So we have to take care, and her age is also 34. So we don't want to waste time. And for grade 4 endometriosis, we can't do much for that grade 4 endometriosis. So it is better that we explain her. First, I'll see the junctional zone thickness by the help of my
the findings
3D
are
ultrasound, because that will give a prognostic value also to me. And on the basis of that, I'll explain that if it is more than 12, I'll have to explain her that
Dr. Manisha, she has gone beyond the junctional zone. Now we are seeing the adenomyosis of 4.5
She has
centimeters.
adenomyoma, but I was just
What will you do?
I'll start with GnRH analog, because I don't want to waste much time for that. And the chocolate cyst I don't think it is interfering. Unless it is interfering with ovum pickup or something.
How long do you want to wait?
Take an opinion of
so let us be a little brief in our answers, because Jayashri is just waiting there. So let's be brief in our
I'll
answers.
give her long-acting GnRH analog.
Wait how long? What do you do next?
I'll give her for 3 months 11.25 mg GnRH analog, and then I'll again reassess. And along with that, after its effect has gone, she'll have a spontaneous periods, which indicates that the down regulation of the gonadotrophins is gradually decreasing. That time I'll give her stimulation and explain her that
Thank you. You have said it right.
And freeze it.
Any views from Parul? Parul, Divya, one sentences. What do you want to do?
Yes, ma'am. I will go with medical management in this case also.
Yeah.
Who is answering? I'm not able to see.
Ma'am, I'm Parul. I'll go with medical management.
Okay, Divya?
Yeah, the same for GnRH is 11.25. I'll wait, and then it's better to go for the second time. We have to advise the patient for the IVF for the next cycle.
Anybody wanting to put in a telescope and do see, it looks such a lovely, here, in fact, the pictures are here. Otherwise, it was looking very well defined. Focal adenomyosis.
It will regress with the GnRH analog. The size decreases almost 50% in most of the cases within 6 months. So
Asha,
if we are giving her a 3 months trial, that will at least reduce it to 25 to 30%. And that will be tolerable for her obstetric, for continuation of the pregnancy and
Ritu wants to say something.
Yeah.
Yes, Ritu, yes.
If you go by the guidelines, madam, if you go for endometriosis or adenomyosis, grade 3 and 4, it's both the same guidelines that they need to be given an ultra long protocol of GnRH.
Yeah.
Thank you so much, all my lovely girls. Everybody is coming out with the right answers. That is medical suppression first and not surgery. And Dr. Chitra, what are the medications available for?
Especially for infertility, madam, or
no, this particular patient, this
particular patient, ma'am, she has already undergone surgery, so I will prefer 2-stage IVF in this patient. First of all, ovarian stimulation, then ovum pickup, then we can go for cryopreservation of those embryo, and then we can give her this thing 3 months GnRH analogs, and after that.
Yeah. Then beautiful. I said you said it right.
Yes, ma'am.
Now these are the various medications available. Danazol, it was a wonderful drug olden days, but because for androgenic side effects, loss of popularity.
GnRH analog, I'll prefer.
Yeah, why do you prefer?
One thing I wanted to say, if the patient is obese, I prefer giving aromatase inhibitors, because in those cases, the peripheral conversion of androgens to estrogens is much higher. So that time you were discussing with ma'am, Neena ma'am.
Thank you. But
that
today,
time I wanted to say that for obese people, it is good. Even for the males who are obese.
Thank you, Manisha. So GnRH is the time-tested medication which is available for last 15 years. When you use it pre-IVF for 3 to 6 cycles, there is decreased expression of aromatase cytochrome P450 in the utopic endometrium of women with adenomyosis and endometriosis. So it is targeted towards both endometriosis and adenomyosis. Decrease in the expression of nitric oxide synthesis.
It reduces the volume as well as
very good regression of volume. Yeah, after 2 to 6 months of GnRH, volume reduction happened from 180 ml to 86 ml. So if you use a long course of down regulation, it can improve the prior to ART or prior to embryo transfer. Definitely increase the clinical pregnancy rate, ongoing pregnancy rate, and implantation rate in patients with adenomyosis.
Yeah.
So these are the various papers.
Long term.
The implantation rate jumped up from 16 to 32%, and pregnancy rate from 24 to 51%, and ongoing pregnancy rate from 21 to 48% when you use long-term GnRH before IVF ET in women with adenomyosis. And the best time for stimulation, somebody said, I think Divya said she would wait for menstruation. And
yes, I also said.
Yeah.
Because once I had heard Dr. Jaydeep Tank, he was saying that the periods when they return, it indicates that the down regulation of the gonadotrophins has slightly tapered off, and that is the best time you give. We can give, if the patient is very young, we can give her time for spontaneous conception. And if we are taking for IVF,
no, this woman, we pertain to this woman. This woman is not young. She's 34 years.
No, for her, we'll start the IVF cycle. So after taking the ovum pickup and fertilizing it and keeping the embryo frozen, because the thing in endometriosis and adenomyosis is there is disparity between the optimum estrogen levels which we require before ovulation. Sometimes when it is very high, we won't get good results. The embryo will get, because of the stimulation effect, the ovum will get. So we have to do both the things in 2 steps. So when the estrogen is high, we take the nice ovum, which is
thank you, Manisha.
We get it.
Thank you. So let me stop here because you are in favor of ultra long protocol. But if she had a low AMH like 1.2, then perhaps you should go in and do an egg collection straight. And then rectify the embryos, and then suppress the adenomyosis for 3 months or 4 months, and sometimes you have suppressed 9 months. I've suppressed a patient last year for 9 months because the adenomyosis was 7 centimeter. And yesterday she had a baby girl born. We were very, very happy because sometimes patients ask, do you have to wait for such a long time? But if you undergo a surgery, you have to again wait for 6 months before you do anything. So it's worthwhile without a knife. They wait for 3 to 6 months to 9 months, depending on the size of the adenomyoma. And every patient, you need not wait for the menstruation. What we do is, we at the end of 12 weeks,
we take it.
Let me talk, Anisha, sometimes. Give me time to talk. Yes. So we have to do at the end of 12 to 14 weeks. This is the time that the GnRH depot 11.2 lasts. Do LH and E2, and sometimes you see they're very, very much suppressed. LH is like 0.01, and E2 also is something like 5 milligram or much lower. So in such patients, you give another 2 weeks. Now the LH starts coming up from 0.04, now it becomes 2, and E2 also came up to 15. So you do not have to wait for menstruation. You can start straight away on stimulation, because when you give estrogen, if in case you give estrogens to make her menstruate, or even the return of estrogen, sometimes the adenomyosis will progress again. This change in volume we have seen in some patients. So there is no need always to wait for menstruation. So see the follicle count, see the follicle size, do the LH-E2, and if it is a decent stage, you can start stimulation. So this particular lady, we waited for 3 months, and the size of the adenomyoma came down to 3.5 centimeter. And we went in for ovarian stimulation, 5 oocytes, 3 embryos. We did a vitrified third embryo transfer, and she conceived singleton. She had a low-lying placenta once again, but not really troubled her. Again, she has a baby of 2 years now. And Dr. Manisha, I would like about 3 sentences. What is your impression about Diagnose for adenomyosis?
We love this drug. Basically, over the fact that it reduces the symptoms drastically, even if it's has a absolutely minimal effect on the volume. It is like anti-estrogenic, and it reduces the estrogen level up till more than 40 picogram per ml, and that is a significant. And the fact that it affects the relieves the patient of her symptoms so drastically, I would always recommend this as one of the first choice of the drug and therapy for this particular thing. It is an anti-estrogenic immunomodulator. It is like an anti-angiogenic, anti-inflammatory drug.
Yeah, right. You're right. So it is good for controlling the pain, pelvic pain, but not very good for controlling the menorrhagia. So if the woman has menorrhagia and large volume uterus, you will not use Diagnose. Whereas a gynec patient requires control of pain, you will give her Diagnose. For patients with infertility, any day, the GnRH analogs better than Diagnose. You are right by saying that it maintains good level of estrogens around 40, so that the disease does not progress and there is no loss of bone mineral density. And whenever you use GnRH analogs, do not use it for more than 6 months. And most often I combine my patients with norethistone acetate, 5 milligram per day, to prevent bone loss. And this is a study by Matsushima et al., where he compared reduction uterine volume for 16 weeks of GnRH analog, low-dose estrogen progesterone, and Diagnose. There was no change in the last two groups. Whereas with Diagnose, from 307, it came down to 177, a very good uterine volume reduction. So for infertility, it is very, very good medication. And Dr. Sangeeta, aromatase inhibitors, 3 sentences only, no lectures.
Yes, we all know that this aromatase inhibitors inhibit the conversion of androgen to estrogen, which is a basic pathophysiology behind the endometriosis, adenomyosis, or leiomyoma. And most of the studies have shown that the efficacy is as comparable to the GnRH agonist in reducing the uterine volume in 3 months up to 60%. And it also symptoms of abnormal uterine bleeding also is controlled with this drug. But yes, the pain is not most commonly controlled with the use of aromatase inhibitors, and it has some side effects of the bone loss. So if you are using for long term, we have to add norethistone acetate. And if you are discontinuing the drug, chances of recurrence is also likely. So we can use it.
Yeah, thank you. Thank you so much. Dr. Ritu, do you have something to say, Dr. Ritu?
Yeah, yes, madam. Madam, I wanted to say that it should not be used as the first line, only as the second line, where you need good volume reduction and it's resistant to the other therapy like GnRH alone.
Yeah, it's a very good medication, but we do not have too many trials. So I would always like to reserve it as a second line of drug. Though the papers came as long as back in 2012 by Badavi et al., where they saw good volume reduction and good reduction symptoms also, 60% volume reduction. But remember, it always causes hypoestrogenism. So you have to use progesterone along with that. Norethistone listed 5 milligram per day. Otherwise, they can also cause follicular cysts sometimes. So it's very important to use aromatase, though I have now about 10 patients where 3 to 4 patients have conceived with adenomyosis. But it is not yet time to speak about it. And Dr. Chitra, what is your impression about this particular patient, Dr. Chitra? 32 years.
It's a it looks like adenomyoma. It's a well-defined lesion.
She already has one child. She has come for menorrhagia, dysmenorrhea, and she has come for secondary infertility.
Yes. Ma'am, she has a large cystic lesion, which is 7 centimeter in size. So it definitely has to be treated. I will prefer to do the aspiration of this lesion. And aspiration we can do either through the laparoscopy or we can do hysteroscopic aspiration of the lesion also. Then,
how do you know it is not a cystic degeneration? Dr. Sangeeta, Dr. Pragati, Parul. How do you know it's not a myoma with cystic degeneration?
Yes,
the vascularity part is color Doppler we have to put.
It did not show any world appearance of myoma and no flow also. So what would Parul do here?
Like to excise the lesion.
I will
As it is circumscribed, a solitary lesion of 7 centimeters, it is indicated for surgery. So I would put in a scope and do an adenomyomectomy.
Yeah, you can do that. And
it is a good case for surgery.
Yeah, this particular patient, we had done a laparoscopic drainage because it was all fluid. And we gave her 3.75 agonist for 2 doses. She went back to Dubai. She had come from Dubai. And then she had a spontaneous conception after 6 months. And she came back to us and delivered a healthy child. Today, that child is 15 years. This happened in 2005. And 2 years back, we excised another cyst from a lady, but she has a male factor and she has not come back for IVF. So we are waiting. So posterior wall adenomyoma, because it was more cystic, we drained it. If it is little more solid, sometimes it's a combination, If it is a little more solid, you can excise it.
So ma'am, we can try drainage at the first line treatment. And if we are not able to drain, then we can definitely excise, because 7 centimeter, we have to do the surgical treatment.
Yeah. Okay. So this is 19-year-old unmarried female with severe dysmenorrhea, not responding to NSAID OCP. She has 2.6 centimeter focal adenomyosis with central area of cystic degeneration in the anterior wall. And Pragati, how will you manage?
She is having a severe dysmenorrhea, and she is not responding to NSAID and OCP. Then and there is the focal adenomyosis only 2.6 centimeter. And there are central area of cystic degeneration. I can aspirate it through the laparoscopy, and then I can give her GnRH analogs, or I can try first medical treatment with GnRH analogs, and if there is no improvement, then I can do it.
Yeah, both are right. But once you put in a laparoscope, there is no point in just aspirating. You have to excise it. It is small. It is not very big. So once you are in, you give her a GnRH, is not responding, you should definitely go in for a laparoscopy, because you cannot give her lifelong GnRH suppression. But there is an entity called as juvenile cystic adenomyosis, which could be perhaps not a real adenomyosis. It could be a remnant of Mullerian fragments. And these girls respond very well to laparoscopic excision, and they are generally anterior wall, not posterior wall. This is the hallmark. They are young women, less than 30 years, and it is an anterior wall lesion, and they respond very well to 2.6 centimeter to laparoscopic excision. So there is no point in just aspirating.
Yes,
so posterior wall lesion may be different from anterior wall lesion, and this could be in a young girl, it could be a juvenile cystic adenomyosis, which can respond very well. So I think it's very important for us to read, gain more knowledge before we jump upon people and tell her, okay, lifelong GnRH analog. So if it's a juvenile cystic adenomyosis, a small lesion in the anterior wall, not responding to medical management, sometimes you're going for a, and she has no other endometriosis, mind you. Okay, so this is for, this is 41-year-old. She's married to her uncle, consanguineous, and she had 6 pregnancies, abortions, 2 neonatal losses, no live child. She came to us asking for egg donation. She said, I've married my uncle, so we cannot change the sperm, so give me different eggs. So I want a healthy baby. And then we saw she had a 6 centimeter posterior wall adenomyosis. So how can you go ahead, Dr. Sangeeta?
Actually, this is a very complex case. This patient already has 2 neonatal losses and 3 abortions with history of consanguineous marriage. So proper evaluation with respect to the karyotyping of both the partners, Sapler syndrome, and other evaluation should be necessitated. And she has also 2 failed IVF cycles with 1 missed abortion. So I think that after proper counseling, we can go for excision of that adenomyoma, suppressing with the 3 cycles of GnRH, and then 1 cycle with the donor embryo, not the sperm, not the ovum, donor embryo. That will be much better.
She has received already
1 cycle.
Yeah, this lady had 2 failed IVF, so she was not looking for surgery. So she underwent 1 more GnRH suppression with donor embryo, and she conceived and she had a missed abortion.
Okay. So then the better to go for.
So since in case of
Yeah. And when she told
Sarojit
us
ji,
surgery, she was
answer, I
promptly lost for follow-up. And she came back after 1 year. Then we told her, no, unless you agree for adenomyomectomy, we will not treat you.
Yeah.
This was 2008. So she underwent laparotomy and debulking because this was 2008. You know, laparoscopic adenomyectomy not so good that time. And then we gave her a post-operative GnRH also. And after that, we gave her embryo donation again. She conceived. She conceived twins and delivered twin daughters in 2009. And this is the uterus post-operatively after cesarean she brought out. You can see the posterior wall has no signs of surgery at all, you know, no additions, no indentation, nothing. She withstood very well. But Dr. Ishita, what are the indications for adenomyomectomy in these patients? I think we have another 10 minutes only. We have to go quickly.
7:26.
Yeah. What are the indications for? Ishita is there?
Ma'am, the indications.
Ishita has left because of the emergency, some emergency problem.
Okay.
The indications for the adenomyosis, this most important if the patient
Who's
is having
answering?
the focal adenomyosis.
Divya, ma'am.
Yeah, Dr. Divya.
Okay, okay, fine.
Since the most important thing is if the patient is having this adenomyoma, that is then we have already discussed, we have to go for the adenomyosis, adenomyomectomy. And also in the patients who are having the intractable type of menorrhagia as well as a severe dysmenorrhea also, in those cases, we have to offer her for the surgery. And the patient who have undergone many cases, this recurrent implantation failure as well as the recurrent miscarriages also, in those cases, we have to advise her for the surgery.
So menorrhagia, recurrent implantation failure, severe dysmenorrhea, and not responding to medication.
And the pregnancy losses.
This is to be underlined. Not respond. I have not underlined, but not responding to medication.
Not responding.
So not for every case. And what are the techniques, Dr. Parul? Briefly, 3-4 sentences.
Ma'am, the techniques available for adenomyosis, focal adenomyosis is adenomyomectomy, and we can do, earlier we used to do a wedge resection, but nowadays we do a bipolar coagulation of the serosa, and we cut the myometrium transversely by a unipolar method, and then we scoop out the adenomyoma. Achieving hemostasis, we do a tight.
Sometimes you can do a uterine artery ligation also, you know.
Yes, uterine artery ligation. Like nowadays we do it, ma'am. In good equipped centers, we can go for uterine artery embolization.
Or you can give a pre-operative GnRH analog.
Ma'am, the pre-operative GnRH analogs, actually the IVF people are more in favor. We as an endoscope.
As it is, there are no planes in adenomyosis, right? It's not a chocolate cyst. You remember it's adenomyosis. You can see there are no planes at all.
Yes,
you go on debulking.
Yes.
So pre-IVF GnRH definitely reduces the amount of bleeding.
Of the adenomyoma.
And go on doing the debulking, but you should have at least 2 centimeters of seromyometrium left on either side. You must give enough tissue.
Yes, ma'am.
Otherwise, you may be left out with no myometrium to suture.
Yes, ma'am. Because the principles of myomectomy apply to adenomyomectomy as well.
Yeah. And see that you do not use too much of electrical energy. My previous slide showed a lot of electrical energy and charring, you know, the previous one. So it's very important not to use unipolar current, use more of bipolar and use minimal electrical energy and good apposition and good 2-layer suturing preferably. If a 2-layer is not possible, then do at least a single layer.
Yes, ma'am.
Very proper suturing is very important. And laparotomy or laparoscopy?
Ma'am, nowadays it's obviously laparoscopy because the tensile strength of the wound is better.
Yeah, even today, Osada et al., who is a master of adenomyomectomies from Japan, Japan has done more than 2,000 adenomyomectomies. He says for focal adenomyosis, laparoscopic surgery is good.
Yes.
Whereas for diffuse adenomyosis, which requires extensive resection, complicated suturing, difficult surgery, kindly do a laparotomy. There is no shame in doing a laparotomy. Our patient, we did a laparotomy, which I showed you. It was a large adenomyosis of 6 centimeters. This is how he does it. You know, here you opens the uterus like 2 leaves and opens even the endometrium, excises everything, and then sutures the endometrium. And the uterus is sutured in 3 layers, like with 3 flaps, not 2 flaps. So in his series, 54% pregnancy rate and no rupture. This is very, very important. So it is not shameful to do a laparotomy. Remember, all of us we came as gynec surgeons. I'm sure many of you can do a very good laparotomy and a debulking. You can do a good suturing, which is very, very important, because the drawbacks of adenomyomectomy are that surgery is not complete, symptoms will persist, recurrence rate is very high, spontaneous rupture of uterus. So if you leave more tissue, where you do not have a tactile sensation, you may not do a proper surgery, may not do a proper suturing. And you may not be able to call the best surgeon to come, and you cannot call Prakash Trivedi or Hafiz Rahman to come to your center and do the surgery. Whereas you can do a good debulking. So go ahead and do it. So do not be ashamed to do a laparotomy. Nobody says whatever you can do to save her uterus from future rupture is the best method. Because in the series of Japan, there was 6.8% chance of uterine rupture. And one of them was a twin gestation, post-adenomyectomy, post-IVF. At 32 weeks, she thought it was contraction. In the hospital, she was getting retardant drip. And during that, she had a spontaneous rupture. She was rushed to the theater, and they could save the babies who were 1.3 and 1.4 kg. But they had no hysterectomy. So doing laparotomy is not shameful. This is something to be remembered. So I think we'll just discuss only one case more. This is post-adenomyomectomy patient. And I'm sure all of you would say that you do a medical management, suppress the uterus, and then do a embryo transfer. And this patient did very well. She was married 15 years and she was 39 years. She did very well with the medical management of 6 months suppression. And after that, she had embryo transfer. In fact, she conceived twins and delivered them at 36 weeks. Hysteroscopy has no place in young patients where you require fertility sparing. It is okay in gynec patients with AUB to do a hysteroscopic resection. You can do a good resection, transcervical resection, remove a part of the adenomyosis, and you may have relief from menorrhagia. I'm rushing through because there is no time. At Rao Hospital in 2016, we had 56 patients, focal in 29 and diffuse in 27. And we had a 44% pregnancy rate with a live birth rate of 68%. Mind you, the miscarriage rate in adenomyosis is still high, 32%, compared to about 14% in non-adenomyotic patients. But 68% with adenomyosis was a very good pregnancy rate way back in 2016. Now we have some more patients. So there is only one question. This lady is a fertile lady. She has one child, 39 BMI, 35 years, LSAS 9 years back, comes with severe dysmenorrhea. What will you do for her? She does not want surgery. She wants pain relief. She had a laparoscopy 2 years back. She has a chocolate cyst with hydro. This is a current scan picture. She has a left chocolate cyst, and she also has a hydrosalpinx. The other ovary is normal. And she also has a posterior wall adenomyosis. She wants pain relief, 35 years. So let us start with Manish. Yeah.
LNGIUS.
Anybody wants to do the surgery, remove the hydrosalpinx, remove the chocolate cyst?
Probably does not want the surgery.
Her previous surgery
got
multiple.
LNGIUS.
She does not want the surgery, ma'am.
So we can go for the LNGIUS.
Yeah, she had a laparoscopy before coming to us, and she also had a partial chocolate cystectomy where she had a lot of adhesions. So you are obese, 39 BMI, you have adhesions. So it's not worth going in for a surgery and getting into a mess. So
medical management.
Medical management, very good. Yeah, LNGIUS. And what is the expulsion rate with LNGIUS in adenomyosis?
Ma'am, if size of the uterus is very big, then expulsion rate is high. So we have to take care of the uterine size as well. Yeah. Ideally, it should not be more than 150 ml. The volume of the uterus should not be large. If volume is large, we can give GnRH analog to reduce the size, reduce the volume.
Right,
of the
you are very much right. This lady, when she came to us, she had severe pain, and she wanted a laparoscopy and remove all these lesions. We said, no, you have a GnRH analog. We gave her 11.25, and she waited for 3 months. And after 3 months, she was sort of having pain relief. Now she was willing to think of LNGIUS, and then she had the LNGIUS. She has done very well. This was 2015, and now it is 2021. She came this year asking, shall we remove the Mirena now? What is your answer to her? It's only 5 years. Do you want to wait longer, or do you want to
5 years ago.
Knowing it's COVID, ma'am, you can continue for another couple of years.
For 5 to 7 years maximum.
1 or 2
Yeah,
years.
you can continue. So we told her, you please wait. There is no need to remove the Mirena now. I have patients who disappeared at the end of 6 years. When we told them remove the Mirena after 6 months, they didn't come back. Couple of them came after 10 years. One lady came after 14 years, saying that I did very well, so I did not come back for a Mirena removal. So lady who had Mirena at 34, she came back at 48. She said, my daughter was 7 years when I put the Mirena, and now she was 21. The daughter was 21. She got married. She had twins. She said, I had no time to come back to you. I was busy looking after my daughter. So now she came at 48 years. Now there was a recurrence of her endometriosis. So she was very happy to, she did not want any further Mirena reinsertion. So she underwent a hysterectomy very happily at 48 years. So LNG-IUS can give very good relief in these patients. Do not be in a hurry to do a hysterectomy or an adenomyomectomy. It has better effect on adenomyosis than combined oral contraceptive, better quality of life than hysterectomy. Most optimal in women with moderate uterine enlargement. However, it was successful in 69% of women with large uteri also. So in these women with large uteri, I give GnRH depot, which lasts for 12 to 14 weeks. At the end of 8 to 10 weeks, you put the Mirena. So the chance of expulsion are much less with this type of insertion. So the initial GnRH therapy can decrease the expulsion and increase the success rate in large uteri. And we do have seen that there is some amount of weight gain, irregular spotting, breast tenderness, but you explain to them about importance of diet, exercise, and they do very well. So I would say LNG-US is a boon to women who do not require fertility and who have adenomyosis. So this lady has done very well. And just one last case for 2 minutes. This is a young girl of 28 years, unmarried, 31 years. She was on COC for 1 year and she was on Diagnose for the next year. And now she has come with severe dysmenorrhea. She's 28 years unmarried. What shall we do for her?
Which excision will be the best for her?
One by one. Okay, let's start from Chitra. Come on. 2 seconds.
Ma'am, I would like to give her GnRH analogs for 3 months. That can reduce the size, and then we can continue with. These days, we are giving mifepristone also, ma'am. So we can try selective progesterone modulator, receptor modulator drugs also. Okay, Pragati, what do you say?
Yes, ma'am. She is having adenomyosis and endometrioma both. I would like to give her medical management and mainly GnRH analog.
Her history was 10 years. She got menarche. She started having dysmenorrhea. She had menorrhagia. She was on hemostatic drugs. At 19 years, she went in for COC. And after 23, she was on Novilon, which she stopped. At 27 years, she was put on Diagnose by somebody. And 28 years, after 1 year of Diagnose, again, she had no relief. So she came to us. Like you said, we put her on GnRH analog. She was very happy for 6 months. Then she stopped it. And again, she has pain. So what shall we do, Dr. Ritu?
I think she should go in for the surgical management. That focal adenomyoma should be removed, and rest the Diagnose could take care of the endometrioma, if any.
Dr. Parul, Dr. Divya?
Ma'am, even I would prefer surgery in this case because it's a focal adenomyoma. It can be very easily resectable.
And most important, she has already taken the medical management.
And you promptly would say, get married, right? I will remove your adenomyoma and next month you get married. Is it possible?
Yes, counseling very much important.
She said, my elder sister, 31 years, is not married, and where is the question of my marriage? So it will be another 3-4 years before she gets married. And in those 3-4 years, all her adenomyosis and choclosis will come back.
Increase.
I'll guarantee that. So definitely, I would not opt for surgery in this lady. This lady, we have told her, again, now we have put her on aromatase inhibitors. She's on aromatase inhibitors for 4 cycles. She is doing much better now because the cost also is much less. And now she is coming back for Mirena insertion. She has agreed for Mirena insertion. And let us wait and watch how she will do with this. Because I feel, excision may not be the right answer. I wouldn't mind giving her a GnRH analog even for 1 year along with the norethistone acetate 5 milligram per day.
Therapy.
And ideally speaking, we also spoke to her about oocyte freezing, but they can't afford it. So I think there is no end to these dilemmas. So far we have only grade B or grade C evidence for management of young girls with adenomyosis and endometrioma. As Dr. Archana rightly said it, the jury is not out yet. So we have to wait and watch and try our own conservative measures as much as possible. But once in a way, you may be forced to do a surgery. But this lady, if she asks you, what is the chance of my recurrence? You have no answers for her. So thank you all.
Thank you, ma'am.
Thank you so
I
much.
think, yeah, we had a very, very nice discussion. To conclude, adenomyosis is a challenging condition to treat in the scenario of subfertility. It's interesting to note that with ART and medical management, there was good pregnancy rate and good reproductive outcome in endometriosis and adenomyosis. But we require well-designed, adequately powered studies to really test the impact of adenomyosis on subfertility. So thank you all. I know Jay is getting impatient.
Thank you. Thank you, Dr. Asha.
Yeah, thank you all.
Thank you, Asha.
We have fellowship courses of ICOG and also fellowship programs of MGR University. Thank you all. Let me stop sharing the screen now. And I thank the wonderful panelists because all of you have done very good. You made it very interesting. Thank you all.
Thank you so much, ma'am.
Thank you, ma'am.
Thank you, Ritu, for joining me.
Madam. Thank you so much.
Yeah, thank you.
Thank you, Dr. Asha.
Thank you. Thank you all. So now I request Dr. Jayashree to take over quickly.
It's going to be a very short session. I'd request all of you to stay back. It will finish in 10 minutes. So we have 5 questions each for participants of 3 Bareilly, Allahabad, Bareilly and Varanasi. So I request first, who's going to be the Bareilly, no? Dr. Shabina.
Team A will be Prayagraj, followed by Team B and followed by Team
Okay, okay. So who will be the first one from Prayagraj, na? From Allahabad?
Yes, ma'am.
You tell me who's going to be the first one?
Ma'am, Dr. Yashi Srivastav will be who is SR.
Okay, Yashi, this will be all on adenomyosis, true or false. That's all. Dr. Vartika has got the answer sheet, so she'll be marking you. So, fundamental difference between fibroid and adenomyosis is that the latter, the adenomyosis, originates from one abnormal cell.
Yashi, are you there?
True or false? Fundamental difference between fibroid and adenomyosis is that the latter originates from one abnormal cell. We are giving you 30 seconds. Okay. Pass. Okay. The answer is it's false. It's a fibroid which is originating from one abnormal cell. Second, adenomyosis is not a discrete tumor. True or false? Yeah, it's
unmute yourself, Yashi.
Yeah, and it's a localized swelling because of penetration of endometrial tissue. True or false? Come on, this is easy.
Yashi, unmute yourself, please.
True. Okay, 1 mark, 1 mark. She opens her account, so 2 marks. Yeah, 2 marks for the right answer. Possible to remove only adenomyosis affected without touching the normal tissue in the surgery. True or false? It is possible to remove only adenomyosis affected tissue without touching the normal tissue. True or false?
False.
Yeah, it's false. We always remove some normal myometrium. True. Yeah. So 2 marks again. Only definitive treatment is hysterectomy. True or false?
True. True.
Wow. Okay. She gets 3. Good. Well done. Who's the second one, Manisha?
Dr. Shabina Bareilly.
No, ma'am. We'll be finishing from the Prayagraj team, ma'am, completely.
Okay.
Dr. Sheila Madeshia, who's an SR, ma'am, from Prayagraj.
Okay, okay, okay. So this is the second one. This is a picture of who's the, I don't know. Can you pin the person? Yes, she's done. So who's the, yeah.
Sheila?
Okay. Okay. So this is a picture of a sonohystrographic. Okay. Can it be used for diagnosis of adenomyosis? You know, is a famous two-step clinic. Yeah, sonohystrographic. By the way, you're doing it for the tubes. Can you still diagnose adenomyosis on sonohystrography? Okay, she passes, so she doesn't get any marks. Yes, it can be used. Is the sensitivity good? Is it true or false? I don't get the answer, so sensitivity is bad. So it is false.
False, ma'am.
Yeah, okay, give her the marks. Then the transvaginal sonography criteria for diagnosis. Enlargement of uterus in absence of fibroid. True or false? I think she's got some network problem.
True, ma'am.
Yeah, true. Good. Give her 2 marks, Vartika. No lack of contour. Listen to this carefully. No lack of contour abnormalities or mass effects in adenomyosis. True or false? This is a googly actually.
False, ma'am.
Yeah, there is a lack of contour. Then last one, linear striations and indistinct endometrial stripe in adenomyosis on transvaginal scan. True or false?
True, ma'am.
Yes, she gets marks. Okay, who's the third candidate?
Dr. Shweta Rai, who's JR3 from Prayagraj.
Okay, hello. We are continuing with the transvaginal criteria for adenomyosis. Color flow within the adenomyosis lesion has low velocity and low resistance. Do I hear the answer? No. True or false?
True, ma'am. True, ma'am.
Yes, good. Decreased uterine echogenicity without lobulations, mass effect, or contour abnormality.
True, ma'am.
Okay. Anechoic lacunae or myometrial cysts seen only in adenomyosis.
True, ma'am.
No, it's false. Myometrial cysts are also seen in genital tuberculosis. Yeah, that's yeah. Okay, then fourth question is, there is a presence of eccentric endometrium in adenomyosis. You see the endometrium here? True or false?
True, ma'am.
Good. Echogenicity of ventral, please listen to this carefully. Echogenicity of ventral myometrium is increased more than dorsal.
True, ma'am. True, ma'am.
No, it's false. The dorsal myometrium most of the time is more increased. It's not the ventral. Okay. What candidate from Bareilly?
Bareilly, Dr. Shabina Khan, ma'am.
Yes, Shabina, please come and on your video. No, I don't like to be talking to a blank screen. The myometrium in this picture is normal and homogeneous. True or false?
No, true.
Good, great, Shabina. Do you see the subendometrial halos in this? Yes or no?
Yes.
Good. The subendometrial, the third one is subendometrial halos are a thin hyperechoic band. True or false?
Yes, true.
It's not a hyperechoic. It's actually, yeah, that was a googling again. Yeah. The endometrium in this picture is uniformly echogenic. True or false?
Echogenic, yes, true, madam.
True. Great, great. You're doing very well. The endometrium in adenomyosis is unaffected. True or false?
True.
In adenomyosis, endometrium is affected, isn't it?
Oh, endometrium
so
is
actually, yeah, we all think, but it's the endometrium. The junctional zone is also part of the endometrium, no?
Yes.
And the endometrium is get affected. No, it goes eccentric, and there are many other, these HOXA2 genes and whatnot. Yeah. The fifth candidate
will be Dr. Kimi Bansal, ma'am.
Yeah, hi. Diffuse thinning of junctional, this is all on MRI, okay? Diffuse thinning of junctional zone seen on MRI in adenomyosis. True or false? Hello. It's a very easy question.
Can I?
Yeah. Is she there, Manisha?
I can't see her. Dr. Kimi? Ma'am, can we move on to the third person for a while?
We can answer other people.
Okay, take the second candidate.
Dr. Divya Mittal.
Okay. Dr. Mittal, diffuse thinning of junctional zone seen on MRI in adenomyosis. Fast.
Yes, ma'am. True, ma'am.
Oh, it's false. We have to see the picture. It's so much thick, no? Okay. Next question. T2 weighted images are better than T1 or contrast to diagnose adenomyosis lesion. True or false?
Ma'am, pass.
Yeah, you don't nod your head. You're giving away the answer.
False.
Yeah, T2 is better, so it's true, isn't it? Okay. TVS is superior to MRI in diagnosis of adenomyosis. True or false?
False.
False. MRI is the gold standard. MRI had a higher specificity than TVS, but sensitivity of both MRI and TVS are almost equal in all studies.
Ma'am, false. MRI is better in
No,
both
it's
senses.
true. MRI has a higher sensitive specificity, but sensitivity is around 80% for both. Last question. Low intensity signal with junction zone more than 12 millimeters is diagnostic of adenomyosis on MRI. True or false?
True.
Good. Who's the next candidate, Manisha?
Ma'am, Kimi Bansal, ma'am, I cannot see, ma'am.
If
Ma'am, I am trying to Kimi Bansal.
we can answer, ma'am, if madam is not available.
Okay, yeah, sure. Whoever wants to answer, please. One of the panelists.
We have two more people like Dr. Shabina and Dr.
Sure. So this is a very interesting case. Actually, Dr. Asha Mam also had interest. 17-year-old girl with severe dysmenorrhea, 6 months. Menarche at 12 years. On transabdominal sonography, we saw 3 by 4 by 2.5 centimeter mass near the cornu. So we thought it's a hematometra. She's not responding to NSAIDs. On laparoscopy, she had a 3 by 3 centimeter uneven bulge on the cornual end. Incised chocolate material was drained. The cyst and the surrounding tissue was removed, and the histopathology showed adenomyosis. This was the picture. It's a very old case. So this patient was juvenile cystic adenomyosis. The first case we saw around 2011 or 12, or maybe a little later, 14. Yeah, 14. So JCA can be considered as a diagnosis, DD, across all reproductive age groups. True or false, Shabina?
True, ma'am.
No, it's false. Across all age groups, you can only consider it
Adolescent.
Yeah. Okay. This was a googly. Then hysteroscopy is the only method to differentiate rudimentary horn from JCA.
Hysteroscopy. Rudimentary horn with JCA.
Yeah.
I don't think it is the only method.
Yeah, you're right. MRI can also be very good. The next one, visualization of both ostia rules out the rudimentary horn. True or false?
Both the ostia we are seeing. Yes, true.
Yeah, true. Medical management has a huge role in juvenile cystic adenomyosis like NSAIDs and OCPs. True or false? False. Yeah, medical patient did not respond. Yeah, this patient also did not respond. JCA has been classified as a Mullerian abnormality in Eschrey classification. True or false?
Yes, true.
Yes, true.
No, though JCA is a Mullerian, it's a kind of Mullerian abnormality, you cannot classify it as a Mullerian abnormality because the uterus is normal, you know. This uterus has 2 tubes and ovaries and everything. So it has the uterus does not have a septa. On putting a hysteroscopy, you can see both ostia. So Eschrey has not yet classified it as a Mullerian abnormality. Okay. Next, who's the...
From Varanasi, Dr. Shikha ma'am.
Okay, hi Varanasi. Yeah. Adenomyosis with multiparity, not impaired. Adenomyosis is associated with multiparity. When we were doing PG, we used to say adenomyosis, okay, patient is 45, do hysterectomy, you know. So associated with multiparity, not impaired fertility. True or false?
It impairs fertility, so it's false.
Very good. Risk factors include induced abortion, spontaneous abortion, and curate touch. True or false?
True.
Okay, good. Previous cesarean section is not a risk factor. True or false?
False.
Good, good. Tamoxifen therapy is a risk factor in postmenopausal women.
True.
Good, good. Completely asymptomatic adenomyosis is completely asymptomatic in 1/3 of the cases.
True.
Wow, she's the first to get. Very good, very good. Full
Thank you, ma'am.
marks.
Thank you, ma'am.
Yeah. So the second Varna
Dr. Manta, ma'am.
Well. Who are you prompting them? Ritu is there. Okay. 8. Yeah. GnRH analog given for 3 to 4 months improves live birth rate. True or false? In IVF. True. Good. Live birth rate in adenomyosis patients lower after IVF due to increased miscarriages. True or false? True. Yeah, because implantation rates are, you know, comparable. When you get a pregnancy positive and then, you know, patient miscarries, many times they have adenomyosis. Yeah. Prediction of implantation rate is a very interesting thing. Prediction of implantation rate may be made by MRI reports of.
Thank you, Dr. Neena. Excellent talk.
True or false?
Ma'am, true.
Okay. Implantation rate lower in junctional zone more than 7 millimeters. True or false?
False.
It is true. Like though diagnosis is above 12 millimeters, any patient with an junctional zone of more than 7 millimeters, the implantation rates are a little lower. Conception rates are better in classical method of adenomyotomy versus the triple flap or the H incision. True or false?
False.
Yeah, good. So this is the 9th, I think Manisha is taking. This is a 32-year-old patient who came with primary infertility of 1.5 years with cycles regular, normal semen, slightly overweight. Okay, and her tubes were okay, her x-rays of this. And this was her sonography. Her AMH was 2.5. She underwent 2 cycles of IUI. So what are the options? Ociples, agonist therapy in IVF, or, you know, will you give her GnRH agonist or you go in for IVF directly?
Ocipal agonist therapy, IVF.
IVF, so you'll go in for IVF. Good. Second, if you're going in for IVF, will it be a long protocol, antagonist, or ultra short protocol?
Long antagonist, ma'am.
Very good. Now she's failed 2 IVF cycles. She's a 32-year-old. Would you go in for cytoreductive surgery in that patient? You saw this isolated adenomyoma, or you'll go in for surrogacy, or will you just repeat a 3rd IVF?
Cytoreductive surgery.
Okay. What is the age limit of cytoreductive surgery in adenomyosis? 32, 35, 40?
40 years. 40.
Yeah. Drastically, the results reduce after 39th year from 22% to 3%. In a patient who's above 40, cytoreductive surgery is not going to help. How many months of after surgery will you opt for cycle? 6, 12, or 18 months?
6 months.
Yeah, good. High or low risk of antenatal rupture after surgery?
High risk, ma'am.
No, after adenomyosis surgery, surprisingly, the risk of rupture has been low. Remember, madam showed you that. So be like the smart sperm. Thank you. Kiss was keep it simple. Madam. Yeah.
The chance of rupture are 6.8%, whereas after cesarean, the rupture is hardly 1 per 1,000, I think. Yes, so 6.8% is a pretty high. That is in the Japanese papers. In India, I'm sure, you know, a lot of youngsters are doing adenomyotomy. It could be higher.
Yes.
So it's very important to have a learning curve, learn to do a good suturing. And hemostasis without using much electrical energy is very important. And do not be ashamed to do a laparotomy.
Absolutely, ma'am. Thank you so much. Should we, can you please proceed to vote of thanks now?
Yeah, sure. Jayashri, it was a wonderful session. Brilliant.
Thank you, ma'am. Thank you for giving me this opportunity. And
I'm hearing you after so many years. Jayashri spent a brief time in Coimbatore, 1 year. So I sort of got to know her.
I really enjoyed working with you.
It was a brilliant session by you.
Yeah, she does it so well, madam. She does it so well.
I know.
Ritu ma'am was my senior. So I'm always
Yeah.
partial to her.
Had a good time.
Ma'am, is there any prize for Jaldi 5?
Yeah. Please, Vartika will be announcing during the vote of thanks. Vartika?
Yeah, yes, ma'am. So we have team Allahabad. Dr. Yashi had 3 answers, so 6 points. Dr. Sheila gave 4 answers, so 8 marks. And then Dr. Shweta had 3 answers, 6 points. So 20 points to team Allahabad. And Bareilly, since one participant was not there, so I think Dr. Shabina gave answers for 2. In her first session, she had 3 right, so 6 points. And in the last one, 2, so 4. And Dr. Divya gave 2 answers right, 4, so making 14. And the clear winner is Varanasi team, Dr. Shikha, all right. And then the second speaker, second participant has 4 right, 8. And Dr. Manisha had 6 questions. So I'm giving last 2 points, 1, 1. So she has 9 right. So 27 points. So Varanasi is the winner. And then we have Allahabad and Bareilly. Well done. Thank you, ma'am.
All the participants.
Congratulations, Varanasi.
Congratulations, Varanasi team.
Thank you,
Manisha.
everyone. Thank you.
Congratulations. Congrats, Shikha.
Thank you, ma'am. Thank you.
Congratulations to the winners.
Congratulations, Shikha.
Thank you so much, ma'am. Thank you.
And it was very interesting session.
Yeah, very nice.
That is
Yeah,
true,
ma'am.
true, ma'am.
Enjoyed
It was
actually
truly
Jaldi
engrossing
5.
session.
We can have vote of thanks by Dr. Manisha now.
Thank you so much, ma'am. It was wonderful session, and indeed it was power packed and so much action, so many questions that were there and we had dealt with. So we are feeling gratitude and not expressing. It's like wrapping a present and not giving it away. And it's not a happiness that brings us gratitude, it's gratitude that brings us happiness. So hereby I take the opportunity to thank you from all my heart, and especially on the behalf of Pan India Endometriosis Symposium. First of all, extend my most sincere thanks to the Almighty God, to our guest of honor, Dr. Ramani ma'am, Dr. Jaydeep ma'am, for being able to shower her blessings and provide their guidance. Our organizing committee of the same, our moderator, our dear Dr. Asha Rao Mam, organizing chairperson, for putting up such an amazing program, your own ideas and elegance of explanation of the subjects. I need not mention my deepest sense of appreciation. To our conveners and quiz master, Dr. Jayashree ma'am, Dr. Vartika ma'am, it was impossible without your constant hard work and ideas and guiding us in the right direction. Today, we had an opportunity to hear an amazing collection of India's thoughts and concerns regarding endometriosis and adenomyosis. Every performance, be from the heart or brain, it will surely bring an encouragement to the Indian society in their coming future. To my esteemed speaker who took their time off their important schedules and helped us out in this particular situation, thank you so much. You have shown and enlightened our minds and shown us a new path. I also extend thanks to our revered chairpersons for their enormous cooperation, for putting up amazing thoughts and inputs, and will always be helpful to us and our future patients. Thank you so much to our esteemed and revered panelists for putting up such a diverse topic into beautiful and crisp capsules. This knowledge will not only help us, but our patients and generations to come indeed, ma'am. To our panel expert, Dr. Ritu Khanna ma'am, we thank you for your enormous cooperation and for putting up amazing thoughts and inputs. An event like this does not happen overnight. And for that, we would like to thank our technical supports, Mirumijest and Alembic, who were well versed with their job. Last but not the least, a big thank you to all the big 4 societies of the Varanasi, Mathura, Bareilly, and Allahabad. Each and every one of you could attend this program and make this event a huge success. We value you and for every moment that you stayed for this program. Thank you so much, everybody.
And both the moderators have done wonderfully well. Both of you speak so beautifully. Congratulations. Keep it up.
Thank you so much, ma'am.
Congratulations, Manisha, Vartika, Jayashree.
Thank you so much.
Thank you, Asha ma'am. Thank you so much for having me here.
Thank you all. Thank you,
Wonderful
Jayashree.
session.
Thank you, Ritu, and all the panelists and the moderators and the Alembic team. I think it was
thanks a lot, ma'am.
work and a lot of support. Thank you so much.
Absolutely.
Thank you, ma'am.
Thank you, ma'am. Thank you, ma'am.
Thank you.
Hello.
Bye.
Bye. Have a nice evening. Yeah.
Bye, Asha ma'am. Bye, Ritu ma'am.
Thank you so much.
Bye, Ritika. Bye,
Bye,
Manisha,
ma'am.
Ritu,
Bye,
Jayashree.
ma'am. Bye, ma'am.
And Monisha.
It was wonderful session, ma'am. Thank you so much, ma'am, for having us.
I know.
We'll have some other time also, some separate sessions like this, ma'am. Chalo, take care, ma'am. Good night, ma'am.
Okay, bye-bye. Bye.
Bye, ma'am.
Bye.
Ma'am. Thank you, Shirish Janji.
Thank you so much, ma'am.
Thank you so much.
Yeah, should I end the webinar?
Yep. Bye.